even before obesity, but obesity produces chronic endotoxemia. Endotoxemia leads to insulin resistance. Insulin resistance leads to all the other problems that we are talking about. Now, I don't know my timing, but I will just quickly go through my slides. So, finally, it all starts with mitochondrial injury. Again, Dr. Srikumar and I yesterday talked about mitochondrial injury. The mitochondrial injury is the first beginning after insulin resistance develops. And the mitochondrial injury leads to all the other liver-related problems. See that the first slide on the other side is normal before you start drinking, okay, or before you gain weight. Yeah. Then it becomes fat. Wealth, migration to United States. You don't have to migrate to United States these days. If you migrate from your village to Kottayam, you gain weight. So, because westernization has crept in, now that goes on to develop cirrhosis of the liver. And now this is, why am I showing this slide? Yes, it is to brag about me. Yes, but it is also a fact that my professor, Dr. B. Kumarapillai, he was an average doctor, very average doctor with no big degrees. He told me, he wrote a paper, 22 cases, about large number of cases, 20 plus cases of liver cancer in a very short period in Trivandrum. So he did not know. He said good number of them have cirrhosis, but a small number do not have cirrhosis. That is fatty liver. Now we know, 50 years later. So my professor, Dr. Kumarapillai, he cannot be ignored. He said something that I couldn't think of. Now, mitochondrial injury is a big topic, and to save time, I wouldn't do it. Now comes the whole story of gut microbiota. Some 15, 20 years ago, I wrote a chapter on gut microbiota from birth to centenarians. Gut microbiota, at birth, when the baby is born, depending upon whether it is vaginal delivery or cesarean, the exposure to microbiota is different. The vaginal delivery baby, not to scare anybody, my children are cesarean section, my grandchildren. It is the normal way of delivery today. So, God made a mistake, is that right? Yeah. Anyway, the vaginal delivery babies are given a dose of healthy bacteria. The cesarean born children are not given that dose, they get skin bacteria. In order to compensate that, man will always devise a trick. In Europe, when the baby is born by cesarean, they will take the vaginal smear of the mother and put it in the baby's mouth. So we are trying to create something similar to vaginal delivery. Now, this microbiota, there are different types of microbiota. You have firmicutes, you have bacteroides. Firmicutes are, in simplified terms, better. So, we ruin our gut microbiota by taking repeated antibiotics. Apparently, the babies are given 6 doses of antibiotics in the first 2 years. And we go on taking antibiotics regularly. We take PPI, that will also affect the gut microbiota. So there are so many things that we do to destroy. Processed meat, processed food. All processed foods are not bad at all. But highly refined processed foods are bad. There is no question about it. Highly refined processed foods. Now, can I give you the list of highly refined processed foods? No. You have to look at you have to find out which one is highly refined. But the mitochondrial injury that I mentioned leads to cancers, liver cancer, liver injury. It's possible that we can stop the mitochondrial injury by certain chemicals, which we will, at this time it is not available, we don't have to talk about it. How do you diagnose fatty liver? You can do AST, ALT levels, you can do a CAT scan. Now the liver has a great advantage. Prometheus, he stole the fire from the god and he ran away. And Zeus punished him. So he was tied to a stone, and an eagle vulture will come and nibble the liver every day. But every day the liver will grow. So something the Greeks in those days knew, that the liver has a tremendous regenerating capacity. Still we believe. If you take away 60% of the liver, still the next day it will grow. Now, native medications. There are native medications to treat. Not to treat, maybe supplementary. There are so many. There may be people interested in Ayurvedic medications. They are all not cures, they are supplementary. Karela is reborn as a new agent. Karela, it doesn't solve any problem. It's one of the fiber containing vegetables, that's it. Now, MFLD therapy, there are various therapies available today. Pioglitazone, and you have metformin. Metformin is the standard one that we start with. So there are so many medications available, and lifestyle modification is the best. Now, to take some credit, India's contribution to the Western world, yoga, okay, yeah, that is exercise, meditation, that we call it stress reduction, is that right? Yoga, meditation and vegetarianism, that Dr. Dennis Burkitt called high fiber. Dennis Burkitt, you all know as Burkitt's lymphoma, but Burkitt's contribution is high fiber. So nobody says that meat is bad, but the idea is fiber is needed, particularly the soluble fiber, because it is the soluble fiber that is converted to short chain fatty acids in the gut, which is the metabolite for the cells. Preventing insulin resistance due to lack of time, I will just go through. There are so many agents for insulin resistance prevention. And the pharmacological management of MASLD is just evolving. Right now we do not have much, but it is just evolving. Semaglutide is approved for treatment of non-alcoholic fatty liver disease. Now I have to come to GLP-1. The GLP-1 RA is used, overused, appreciated, or hated. I will tell you, many of my friends who are on GLP-1 RA, they don't do exercise, they don't do stress exercise, they just take the medication. They don't increase the protein intake. They are all now sarcopenic. They are all sarcopenic, they are not able to get up. Do they look better? No, they don't even look better. So that is unfortunate thing. Okay? So now this is the situation. Now I have to come to my favorite. Now I have to come to my favorite. We were told that Mahabali is a candidate for MASH. Is that right? No. Onam is coming next week. We will go around the town to find out which Malayali has the biggest belly, and we will make him the Mahabali. Mahabali, I have to correct it. Mahabali means somebody who was healthy, strong, muscular. Raja Ravivarma had drawn the picture of Mahabali, who is a very strong, healthy man who is there. And we called it Mahabali. He is not Mahabali, he is Mahabali. Now, so real Mahabali is there on the right side. So don't think that Mahabali is an unhealthy, fatty, obese man with metabolic syndrome. He is not. He is not. So now learning points, body fat comes in several forms, white, brown, adipose tissue is an endocrine organ. Obesity is plural. So there is a healthy obesity. One thing that I did not mention is, if you gain weight, but if your thighs are big, if you gain fat in the thigh, it's good. Thigh fat is protective. So now you know where to deposit your fat. Is that right? Yeah. So, NASH is MASH, and liver transplant now unfortunately is performed more for metabolic disorder induced fatty liver. It's unfortunate. And drinking, there is now the benefit of one drinking is a story. Somebody, a liquor merchant, wrote it. Okay. Alcohol is a potential toxin. Within limits, one teacher used to tell me in this country, we have to teach people how to drink. Okay, that still remains. Now, Thank you very much. I will be happy to answer.
Thank you, Dr. Pichamani, for the educational, informative, and entertaining presentation. I invite Dr. Prasad. You have
Hello, let me introduce Dr. Narendran from Lubbock, Texas. You met him yesterday as we honored him. Today, he's a GI specialist giving an award to Dr. Pichamani, who's a GI specialist. So we're going to come up to the podium and give our picture with the SCME committee. This is historical for us. Okay?
The greatest honor in my life. Congratulations.
Yeah, this is video. Somebody had to everybody take the picture, please? Yeah, somebody had to do it. Okay. That's fine.
Our next presenter is Dr. Vijayanand, belongs to the 1979 MBBS batch of Trivandrum Medical College. He had his training in otolaryngology from Trivandrum and Madras Medical College between 1986 and 1991. He's trained in micro-ear surgery under Professor K.K. Ramalingam, a renowned otologist in Chennai, until 1994. After a brief stint in the Thrissur Jubilee Mission Hospital, he moved to the United Kingdom via the Overseas Doctors Training Scheme in 1996 and became a fellow of Royal College of Surgeons in Dublin. From 2006, he subspecialized in audiovestibular medicine and completed MSc from the University College of London. At present, he works as a neurologist, AVM physician at Epsom and St. Helier Hospital, Surrey, managing both adult and pediatric populations. He's also the training program director, Health Education England for Audiovestibular Medicine, and member of the Special Advisory Committee for ENT at AVM, Royal College of Surgeons and Physicians, respectively. Let's welcome Vijayanand.
Thank you very much for the kind introduction, and I thank the organizers for giving me this opportunity. I know it's going to be a very hard work following Dr. Pichamani, sir, but I'll try my best. Yeah, my topic is dizziness, and it's a very common problem. I'm pretty sure that most of us, if not all, might have had at least a brief experience of this symptom sometime in our life. That's not the only reason I picked this. Some of the slides have gone missing. Thank you. Yeah. Sorry for the mix-up. As this slide shows, dizziness is very common, and the incidence of dizziness increases all over the world. Balance or imbalance is not treated properly. So it's even though recently there is a more push, even in US, UK, and even in India, there is more systematic management of dizziness, moving away from pharmacological and going towards rehabilitation-based therapy. So in many patients are happy with the diagnosis of vertigo. Many will come and say, oh, I have vertigo. So what it means is it's only a symptom, like I have fever. So treatment of vertigo is based, concentrate on treating the symptom without identifying the cause. So you know that then it's not the right way. So in chronic dizziness, these symptoms should be managed and sorted at the onset. Otherwise, chronically the people maladapts, then there is an avoidance behavior, and this can even lead on to depression. So the next slide shows, so I'll touch upon a bit of anatomy and functional anatomy and physiology, because to understand the clinical signs and symptom and interpretation of result, we should have a very good knowledge of basic postures. Now coming to management of posture, yesterday Sriumaran has mentioned about advantages of a big brain because of bipedality, but it comes with a price, because erect posture is inherently unstable. It's an inverted pendulum with a heavy head on the top and very narrow base. This is complicated by a high center of gravity. So what happens is like a ladder with a heavy lead ball on top. So when we walk, the center of gravity is within the base. Even when we run, it is there. Once the center of gravity goes out of it, you fall. Based on these facts, it's a surprise that we don't fall that often. We are put through a lot of stress through the system, and we maintain that by, in short, I can say that it's a constant feedback, closed loop feedback mechanism. How it works? Through input from three important input through the visual system, proprioceptive system, and vestibular. It goes to the brain, and then the output comes. This will describe a bit more. So the vestibular, visual, and proprioceptive, hearing and auditory also contribute. Then there are other supplementary system. It goes to individual central processors. Then it goes to our master central process, that's brain, and the output comes as stabilization of gaze. Even if I move my head really fast, I can focus on things, but if I move something in front of my eyes, I won't be able to read. That's how our fixation helps. Then it doesn't stop there. Once you make the postural changes, the adaptive control, there is finer adjustment. You think the step is this high, you miss by a little bit, immediately brain recognizes and it corrects it. And the sensory system keeps on feedback. It's a constant monitoring of the system. That's what I mentioned about the closed loop. And the erect posture is maintained by constant monitoring thanks to our anti-gravity muscles. We don't even think of how we stand. Without our awareness and concentration is constantly maintained, our posture is maintained. Now, I didn't declare a conflict of interest earlier. All these three, I think this is the super one. Vestibular system, my favorite. Because I call it as a sixth sense. Only difference with this sixth sense is that you will become aware of this only when we lose it, unlike other senses. And I can't go away from this slide without telling about the ears. It's an engineering marvel. It's such a tiny organ. and it can pick up, the hearing system can pick up a tiny vibration in picometers, a size of an atom, to large bomb blasts. So the same organ, tiny organ, no other equipment has been found by human to such a, and the reflexes from the auditory and vestibular system is nearly 1,000 times faster than our visually mediated reflexes. So that's my favorite here. Now briefly the anatomy, we are just to quickly mention for lack of time, this is the cochlea, this is the vestibular system, the nerve is 8th nerve, and these are semicircular canals, anterior, posterior and horizontal, utricle and saccule. Semicircular canals detect our angular motion, and utricle and saccule is the linear and all the 3 planes. They work together, and this is very interesting fact about the evolution of inner ear. So if you look at the zebrafish, where it started first and going through chicks and mouse and humans, it's almost similar. So it's a very old, developmentally very evolutionary, very old. So it's very sturdy. It goes on working until very, even when we are very old. So the microscopic structure quickly. The utricle and saccule, the semicircular canal has this cupula, where it's a gelatinous structure on the covering the hair cells. Similarly, the utricle and saccule has a gelatinous structure on top with the calcium carbonate crystals. These are very important, because if it's loosened and it goes to the wrong place, it causes benign position or vertigo. I'll come to that later. Look at the hair cells, you can see some lines below. So even in resting phase, it continuously sends signals so that the brain is aware. And even inner ear has a very good redundancy, how the nature has created, such that even when one side is completely gone, the other side can pick up the movement in all the planes. So even at rest, it goes on sending signals. Then vestibular nystagmus quickly. If it's a fast component and a slow component, interestingly the slow component is picked by, produced by the inner ear, and the fast component is the corrective one. And in the central nervous system there is vestibular nuclei. Cerebellum is very important, even though it's not directly involved with the vestibular function, but it is very important in the smooth functioning of the vestibular system. Then a part of cortex is also involved. So it's there is something called efferentoscopy. It's a memory bank. As the baby grows up, walks, runs, the information is stored in the system. It's like reading and listening. We don't read each word, or it's a pattern recognition. Similarly, the body recognizes when the signals are coming as a package from all these systems. It has an internal image of where your body is, and so it makes necessary adjustment very quickly. So, that's what it's meant by when a set of sensory input comes from all the system, brain has immediately an image of where you are and how you are standing, and it can make finer adjustment depending on the surface, whether it's a soft or a firm surface. Then coming to dizziness, there are various types of presentation. It can be one singular episode, and sometimes it can be recurrent in between baseline balance going back to normal levels. So otherwise it's a chronic one. Sometimes it's a chronic with an in between recurrent ones. This is very important because you can post-box to things. As you take history from there, you can narrow down your possibilities of diagnosis. Then from the system, it can be from one system, or peripheral is from the vestibular, or from multi-system, cardiac condition causing a giddiness, or it's a combination. Multisensory means people with visual difficulties and inner ear problems. So central, there are various central nervous system conditions can cause dizziness, imbalance and vertigo, a combination of these as well. Then factors influencing is duration of presentation and age. and which are the systems involved and how much the brain has compensated. And also nowadays influenced by media, they read the internet and decide on the diagnosis and come with the conceived ideas, and that's difficult. Now, when, as I mentioned, we don't think about our balance, just get up and walk if everything is normal. So when the balance becomes abnormal, it moves from, it becomes more subconscious to a conscious one. Then we start looking where you're walking, it's an effortful one. So you are going to use more brain energy. So that makes you tired. So and you can't concentrate, and the memory issues. Patients with chronic imbalance come and tell a doctor, I think I'm getting dementia. But the basically underlying problem is their imbalance and their, the consequences of that. So diagnosis, I purposefully put history in very bigger fonts. And many in primary care, you know that your time is limited. You have to take a very good history. If after a good history you don't get an idea about the diagnosis, it's very difficult to get more with your examination or investigation. Use investigations and examination to verify your historical findings. So what do you find, try to find from history? Everything, right from the beginning. They may say, oh, I'm DC for 2 years, but you ask, have you had any problem 20 years ago? Because there is something called temporary decompensation. There may be an insult in the past which was compensated by brain. Later something else happens in life and the old symptoms raise their head. Then about the progression, and look for red flags. That's very important. If somebody says, I lost consciousness when I felt vertigo, so that's a red flag. Then, then neurological things like weakness or sensory issues along with that, those are red flags. So then medications are important. What are the medications they are taking, and also other medical conditions. Now, I'll briefly mention about a few conditions which are very important. So, benign paroxysmal positional vertigo is the most common condition of affecting the peripheral system or vestibular system we see in our practice, and it's usually we see it after head injury. One important thing, there are papers already that especially in South Asian or Asian population, they have very low vitamin D. That is a starting point, because autoconia in the utricle are calcium crystals and there is some role there as well. Then usually we see after head injuries, falls, even whiplash injury. And this loose autoconia goes from the utricle, get into the semicircular canals. So when we lie down, initially the eyes and the neck tells the brain you lie down. So the fluid moves, and which in tandem with the other input. But once the fluid stops moving, because of the gravity, these crystals move, and that makes you give us disease sensation. The typical history, it won't last for too long until only the crystals stop. Then when you get up again, it goes the other way around and produce symptoms. The history is very important. And most of the cases, they get well by itself. Either the autoconia gets out or it gets dissolved. One important thing is it can be completely cured with those particle repositioning maneuvers. The patient suffering for 6 months, 1 year, they come and they think we did some magic or miracle, because they walk out of the clinic feeling much better and steadier. And even we, in those cases of recurrence, we teach them how to do it themselves. It's very easy. Not the Epley maneuver, there is something called Simon which can be easily done as well. Now, Meniere's disease. It's one of the most overdiagnosed conditions. Quite a few come with the clinic with Meniere's, because classically it should have that triad of symptoms: patient feeling vertigo, hearing drop, as well as roaring tinnitus together. So many people have some bit of hearing loss, bit of tinnitus, and when they get vertigo, they are labeled as Meniere's, and it sticks. So occasionally they get one-sided ear block. Many patients come and say like a golf ball stuck in the ear. So this diagnosis is important, to be looked at very carefully because of this next one. Migraine related vertigo. It is the commonest spontaneous recurrent vertigo we see in our practice. And these are the ones most often labeled as manias. And it is a great mimicker as well, the migraine. It comes in different forms and shapes. So, but most of them will have other migrainous features. One important thing to remember, you may not always get headache with vestibular migraine. They might have had migrainous headaches in their teenage years or early years. Then it completely stops, especially in women during childbearing years. The migrainous headache is much less, but it comes back around perimenopausal time as disease symptoms. And the history is also very important. And sometimes when you don't get, even if you don't get headache, they may say that I'm still sensitive to light and noise. I prefer to be going to a quiet, dark place and lie down. And another catching point is, oh, if I get to sleep, I wake up feeling better, but I will be very tired. So this is one condition we should all keep in mind, and it should be treated exactly like a migraine. Then acute vestibular neuritis is not very common. It presents with usually only one episode, and it's severe vertigo, severe vomiting, and slowly over a period of 6 to 8 weeks they get better with central compensation. And the important thing is the recovery depends also on their mental health, and we should not give vestibular sedatives like chlorperazine for too long. Labyrinthitis, same as neuritis, but hearing also drops. Oh, this is one of the hot topic. You will see this in newspapers and all, called pre-PD. And this is some patient comes that, oh, I had a vertigo. After that, I am always feeling I am rocking, moving whenever I stand up or walk. So this is, these are the ones I mentioned. If the acute vertigo or acute dizziness is not treated on time, they can become somebody with this condition. In the past, it was called as phobic vertigo or subjective vertigo, or even purely a psychiatric disorder. So this is a mismatch between the vestibular input, sensory input, and also the maladaptive signals. So the visually induced vertigo we see very common, especially in migraineurs. They say, oh, I go to a particular supermarket, I feel very dizzy, I have to hold on to the trolley. But the catch is, as soon as they come out of the shop, I feel suddenly better. So this is visually induced vertigo, and also patterns on the floor. If it is really bad, even the blinds moving or the lines on the floor or patterns of the tile can make dizzy. Even when, I still remember one patient, doctor, don't move your hand, I'm feeling dizzy. So in front of they are very sensitive to that, especially the migrainous group. So some other conditions to keep in mind, acoustic neuroma. Even though it is originating from vestibular nerve, it's called acoustic neuroma. Very rarely it causes acute symptoms because it's a slow growing, giving brain to adapt. Autoimmune inner ear diseases, more and more recognized, fluctuating hearing loss, progressive vestibular hyperfunction. Bilateral vestibular hyperfunction, I have seen quite a few means more than a dozen missed because they are admitted for a surgery, had complication in the intensive care, given gentamicin. When their recovery is prolonged, they blame it to the original illness without realizing it may be a bilateral vestibular failure. Then small vessel disease with white matter changes. You do all the investigation for somebody out of balance, unsteady, you don't find anything, but this is very important because the smooth flow of signals are needed for maintenance of balance and posture. Even in tiny spots shown as white matter can disrupt the movement of that. Like one signal failure in a junction in one line can cause traffic jam all over the place, in a whole area. Similarly, white matter changes are very important. And other CNS condition I am not going through. So multisensory dizziness syndrome is very important, especially in elderly with multiple systems involved, and especially in the United Kingdom, quite a few hospital falls of these patients with visual difficulty, hearing issue in a strange environment. At night they get up and think they are at home and walk in the wrong direction and fall down. So now they are aware of that and they are careful. So the management involves managing each and every bit, correct their diabetes, because quite a few of them have peripheral neuropathy. Then if they have hearing issues, put a hearing aid like that. Now, this slide gives a rough guide to how the symptoms you can postpone those likely diagnoses. If they come and say, I'm going to faint, the blurring of vision when I get up, it's most likely to be a cardiovascular event. If they say, I'm likely to fall, I'm a very unsteady, you have to take more history, but it might point more likely towards a neurological cause. If they say that I feel severe vertigo or the field of vision is tilted, it's more likely to be a vestibular. Someone comes and say, I'm always dizzy. If I sit, stand, walk or lie down, it's more likely to be an anxiety related or a psychological thing and not anything organic. So management as active as possible, review of medication, control of other contributory factors, limited use of vestibular suppressants and specific treatment in the conditions I mentioned, then customized vestibular rehabilitation. Now we promote, like earlier we mentioned about yoga and meditation. Now they labeled it as mindfulness. It's a modified, it's a, like many other things, the yoga has become, the meditation has become mindfulness, and we encourage them to do Pilates and yoga as part of the vestibular rehabilitation. So, and management of avoidance behavior, anxiety and fear of falls. I can tell you fear of falls is contributing to falls, because if there is a slippery surface, you are trying to be more careful, you are definitely going to slip. So same way, the fear of falls is like a vicious circle, make things worse. And to summarize, dizziness is caused by a wide range of conditions. As in any other condition, accurate diagnosis is very important, and vestibular migraine you keep in mind, it's the commonest cause of spontaneous vertigo. BPPV should be identified because it can be completely cured, even if it's easily treatable, and rehabilitation exercises are very important. And peripheral vestibular disorders are more common than central because these can be managed, so it should be identified on time, and it has a major role in elderly falls. Thank you.
Thank you, Dr. Vijayanand. As a fellow otolaryngologist, I understand how complex this topic is, and thank you for your work. Anybody has questions?
Hi, I'm working as a hospitalist as well as I'm an urgent care. I do a lot of the Akmg maneuver in my office. What is the other procedure you are mentioning, and can you explain it?
Yeah, it's called sideline test, or start the sideline test, or the procedure is called Simon maneuver. In many of the epi, you have to do the head movement. Many of the patients have a neck problem and you can't do it. And some of the obese patients, like Pichupudi sir said, we can't do epi in a hospital couch as well. So this is, and also people with hemiplegia, frozen shoulder. So like epi, the first position is same. You turn the head 45 degrees and you do the test and wait for the spinning to stop, and you take 180 degrees to the other side. So the nose pointing up will be pointing down. So I'm lazy, so I can do it in 1 minute. The other one you take 3 to 4 minutes, and also good for my back as well. So, and also the patients say, even with bad back, you are moving as a whole unit. You are not touching, you are moving your head. So as I told you, I did the Simon in a patient who had carotid endarterectomy, and 2 weeks later, the patient had very bad BPPV. So it can be, so there is no neck movement involved. It's SCMONT, Simon maneuver.
Actually, we can catch these speakers after if you have more questions, okay? We'll go on to Dr. Prasad. Come down.
Hello, may I invite Dr. Veena Kamalavital, who's a psychiatrist neurologist from Tampa, Florida, who's going to do the presentation to Dr. Nair.
It was an excellent presentation, but as a neurologist, we hate to see these sinners patients. They come and say that my ENT said nothing wrong with my ear, what's wrong with me? So it's a challenging case for a neurologist.
Thank you. One of the neurologist professors in US, I couldn't get that quote. He said, my head drops when the patient comes and sits in front of me. He said, I am busy, doctor.
That's why I said I am glad he's doing the work. As an otolaryngologist, it's a tough thing for me. And I'm glad to see the next generation is getting into otology because it's a really challenging topic for people to study and to help our patients. We'll go on to the next speaker, Andrew George, MD.
This is a special introduction because I got to meet Andrew when he was only 14 years old. I had to calculate back. So pretty impressive where he's at right now. Andrew George is a fellowship-trained orthopedic surgeon specializing in sports medicine. He has a specific interest in knee, shoulder, and elbow surgical and non-surgical care, including knee cartilage preservation and shoulder replacement surgery. Born in St. Louis, he completed his undergraduate studies at Northwestern University, and he graduated summa cum laude. He then completed medical school at Northwestern Feinberg in Chicago. He completed his orthopedic surgery residency at Houston Methodist, where he was also chosen to be the chief resident. He then pursued his orthopedic surgery sports medicine fellowship at Stanford, where he gained subspecialized training in complex arthroscopic and open knee and shoulder surgery. He has previously served as a team physician for the Stanford football, Stanford baseball, and the athletics Major League Baseball team. He has authored numerous publications and book chapters, and is a reviewer of Arthroscopy, the Journal of Arthroscopic and Related Surgery and the American Journal of Sports Medicine. This fall, he will be returning to Houston Methodist, my hometown, in Houston, part of the Texas Medical Center, to be a faculty member. Thank you.
Thank you so much for that introduction, and thank you to Akmg for this opportunity to speak today. I chose this topic because regardless of what specialty you're in, you're likely to encounter a patient, or probably more likely a family member or friend who has knee pain. And in fact, some people in this room have asked me about their own knees, so I know in fact that this hopefully will be useful to you. This is my attempt in 25 minutes to answer all your questions about your own knees too. I have nothing to disclose, so we're going to talk briefly about the epidemiology of knee cartilage injury, causes and risk factors, how these patients present and how we diagnose them in the clinic and with imaging. We'll talk about non-operative management to start, and then a specific area of interest of mine is knee preservation surgery, joint replacement surgery as well, and then some promising research that's on the horizon. So why is cartilage uniquely vulnerable? We know that cartilage doesn't have a blood supply, and so it can't mount a healing response to injury. Furthermore, it doesn't have a nerve supply, and so oftentimes patients present when the damage has progressed and the damage has affected the surrounding tissues and the subchondral bone. We also know that chondrocytes, or the cartilage cells, are trapped in matrix and they cannot migrate to fill a cartilage defect. And once damaged, cartilage tends to degrade progressively unless we do something about it. So we know that the prevalence of knee cartilage disease is quite high. When we go in and scope knees for other reasons, so put a camera in a knee to take a look at the knee, almost 2/3 of those knees will have some form of cartilage disease. We also know that from a joint replacement standpoint, over 1 million total knee replacements happen in the US every year, and this is growing. It's actually the fastest growing musculoskeletal diagnosis in orthopedics, and currently affects 1 in 7 adults over the age of 45. So what causes knee cartilage disease or arthritis in the knee? We have several causes, both mechanical and biologic, that play a role. So one, trauma can play a big role. Acute chondral injuries from sports, from falls, from other injuries that might happen play a role. Osteochondritis dissecans included. This is more of a pediatric condition, but where there's a vascular disruption of the cartilage. And then malalignment is a big factor as well. So in a patient that has knock-knee alignment or bow-legged alignment, we call that varus or valgus deformity, it can concentrate load on one side of the knee or the other, and that predisposes patients to develop cartilage disease as well. We also know that the meniscus plays a big role. So in patients that have had prior meniscal injury or prior partial meniscectomy, that tends to accelerate wear on the side that they had their meniscus disease or surgery. And then finally, ligament instability as well. In a patient that's had an ACL rupture, whether it's treated surgically or non-surgically, in 10 to 15 years, almost 50% of those patients have arthritis, which is quite staggering. So this illustration depicts the malalignment that I was referring to earlier. So in the middle of the screen, you see a normal knee alignment. And so you see a line that's drawn from the center of the femoral head to the center of the ankle. We call that the mechanical axis of the limb. And normally it should pass through the center of the knee. In a patient with varus malalignment, as seen on the left, you see that the mechanical axis passes towards the medial side or the inner side of the knee. And so that overloads the medial compartment of the knee. Similarly, a patient that's knock-kneed, as shown on the right, or valgus malalignment, that mechanical axis will pass through the lateral side of the knee, and they'll tend to develop lateral compartment disease or lateral arthritis. This is also true for the patellofemoral joint. So this is a sunrise x-ray showing the kneecaps sitting in the femur groove. And you see in this patient has lateral patellar maltracking, and that causes lateral patellofemoral arthritis or joint space narrowing because of that. In terms of additional kind of non-mechanical risk factors, so we know that genetics plays a big role as well. Some studies have quoted the heritability of arthritis in the knee at 40 to 60%, so it can play a big role. Obesity also plays a big role, with each extra pound causing 4 pounds of force through the knee. And so we learned earlier today to deposit our fat in our thighs and not our belly, and I would add to that to deposit in the thigh that you're not having your knee pain in. We also know that age-related wear plays a role too, so the cartilage cell density and proteoglycan content tends to decline from the 3rd decade onward. And then more recently, we've become more appreciative or aware of gender or sex differences as well. So we know that the female sex has a higher prevalence of OA of the knee, specifically postmenopausal, and there are hormonal and anatomic factors that are implicated in that. So what brings patients through the door? How do they present? Typically, they'll present with joint line pain, worse with activity, swelling, effusion, mechanical symptoms, often catching or clicking or locking of the knee. In cases of chronic cartilage disease in the knees, often patients will have stiffness as well, especially after inactivity. And then they can also feel a crunchiness or crepitus in their knee, specifically with patellofemoral disease. In terms of examination, it's pretty kind of correlative with the symptoms as well. So you can palpate for effusion, for joint line tenderness. There are certain specific or special tests that we do, like the McMurray or patellar grind test, and also applying the varus or valgus stress on the knee to essentially overload one side of the knee or the other and determine if that reproduces pain. Of course, physical exam and history can only do so much for a condition like this. So really, the way we really diagnose this is with imaging. So we start with plain radiographs, typically getting weight-bearing AP and lateral views of the knee. And really what the x-rays show is not really what's there, but what's not there. So we don't actually see the cartilage on the x-ray, but we can see joint space narrowing, bone spur formation, and then I mentioned earlier the alignment and how that plays a role. So oftentimes we recommend getting full leg length films, so hip to ankle films on these patients, so we can really assess their alignment and see if they're in varus or valgus malalignment. The gold standard though or rather after getting an x-ray, the best way of visualizing the cartilage is to get an MRI. And so the MRI can show really good clarity of the soft tissues. The standard of care 1.5 and 3 Tesla MRI has a decent sensitivity and specificity for detecting cartilage disease in the knee. It's not perfect though, and so as a result of that, to really actually see the cartilage, we go in with the arthroscope or with the camera and take a look at the cartilage. We looked at looking at 7 Tesla MRI, so a higher field strength MRI, and seeing if that had increased sensitivity and specificity of diagnosing cartilage defects in the knee compared to standard of care MRI. And so basically we had patients that were already enrolled or already signed up for surgery for various reasons. With the standard of care MRI, we then had them get a 7 Tesla MRI, and then we compared whether the standard of care MRI or the 7 Tesla MRI correlated better with what we saw in the scope. And we found that 7 Tesla MRI did have increased sensitivity for detecting cartilage defects in the knee, but interestingly it had decreased specificity in detecting chondrosis of the knee. And so there's still certainly a lot of work that needs to be done to improve MRI. This is just a depiction to show what this looks like. So you see a 1.5 Tesla scan, a 3 Tesla scan, a 7 Tesla scan, and then the same patient we took to arthroscopy, and you see there patellar cartilage disease. You see on the 7 Tesla scan, it's kind of maybe hard to see from the back, but there's a lot more contrast that you see at the patellofemoral joint, and so it's better able to detect cartilage disease, but it may actually make the pathology look worse than it is. So now let's talk about a little bit about treatment. So the vast majority of these patients, we start with non-operative management. Bracing can be helpful, especially if the disease is affecting one compartment of the knee. So really one of the most common parts of cartilage disease in the knee or areas is the medial compartment of the knee or the inner aspect of the knee. And in these patients, unloading that side of the knee with a brace can be very helpful. So the picture there is an unloader brace which applies a 3-point mold on the lateral side of the knee and essentially opens up that medial part of the knee to help decrease load on that side, and patients tend to feel a lot better after that. There are other newer braces that can affect the lateral side of the knee, so open up the lateral side of the knee as well as the patellofemoral joint as well, and there's actually even newer 3D printed custom braces that have recently come out that can be used to offload multiple compartments in the knee. Activity modification is a big first-line treatment as well, so we counsel our patients to avoid high-impact activities, specifically running. Running can, over time, accelerate degeneration in the knee in a patient that already has cartilage disease. Avoiding pivoting sports, and then transitioning to lower-impact activities such as cycling or swimming or elliptical. And then, as I mentioned earlier, weight loss is probably the single most powerful modifiable risk factor when it comes to reversing or slowing down the progression of cartilage disease. Physical therapy can be a helpful adjunct as well, especially in cases of earlier cartilage disease. It tends to be less effective in full-blown arthritis, but in a patient with a focal cartilage defect or early grade 1 cartilage disease, it can really help realign the mechanics of the knee. Specifically, strengthening the quadriceps muscle is probably the single most important aspect of this. So we know that the quad muscle tends to shut down after any insult to the knee, whether it's meniscal, ligament, or cartilage. And so really getting the quad to refire is important. We often do 6 to 12 weeks of formal PT before we move on to something more of an intervention. So injections are a big non-operative strategy as well, and have kind of gained a lot of popularity in the last few years. Kind of the gold standard, or the traditional gold standard for this, was a cortisone injection or corticosteroid. And this is purely an anti-inflammatory treatment, and so it's really recommended for an acute flare-up of a cartilage injury or acute flare-up of arthritis. It can have rapid pain relief, and there have been good randomized studies that show that it has beneficial outcomes. However, in the last couple of years, there's been more research to suggest that repeated cortisone injections in the knee, especially with early disease, can accelerate cartilage wear over time. And so in a patient with a focal cartilage defect or really early arthritis, we try to avoid repeated cortisone injections. In a patient with end-stage arthritis, where we're really just trying to push off a knee replacement, we can do repeated cortisone injections every 3 to 4 months because we're not really worried about accelerating their wear. The second injection therapy that we often recommend is hyaluronic acid or viscosupplementation injection. So this is essentially a gel injection, and the idea of this is in theory, it's restoring the synovial environment in the knee, or allowing the cartilage surfaces to glide smoother between the femur and the tibia. In reality, this is probably most effective due to its anti-inflammatory properties. It's been FDA approved for knee arthritis and often done in a series, most commonly a 3-injection series. It's best for mild to moderate OA and patients seeking to delay surgery. And just as a practical note, it is often requiring insurance authorization, so we'll typically see these patients in clinic, submit for insurance authorization, and see them back and then perform the injection. PRP is the third and probably most popular one currently. For those who aren't familiar with this is where we draw your own blood, we spin it down and isolate the platelets and increase the concentration of the platelets, and then we inject the platelet-rich plasma back into your knee. It's, initially when it came out, it was thought that this was hopefully going to regenerate cartilage in the knee. It hasn't been shown to do any regeneration, but it's stimulating chondrocyte activity, and there's some theoretical benefits from that as well. We know that the growth factors in the PRP can modulate inflammation and provide this kind of environment that's helpful for chondrocytes. There has been a fair amount of research that supports that PRP can be effective in early arthritis, so whether it's focal cartilage defects or focal unicompartmental disease. A lot of people ask what, in orthopedics PRP, what is the best indication for it? The two most studied indications in orthopedics are early arthritis in the knee and tennis elbow. So just goes to show that it can be very helpful in patients with early arthritis. The limitations for this is that there's not really a standardized way of administering it, so there's varying concentrations of platelets. And so at the initial stage, especially as a primary care physician referring to get a PRP, I recommend referring to somebody that's very familiar with PRP that does a lot of it to make sure that they're doing the correct leukocyte content and concentration. A lot of patients will also ask about stem cell therapy as well. So this is not FDA approved in the US, but a lot of our younger athletes, even professional collegiate athletes, are very interested in stem cell therapy. They'll often go to other countries, to the Caribbean, to Mexico, to Europe to get these stem cell injections. And a lot of this, again, is kind of theoretical benefit. There hasn't been any evidence to suggest that stem cell injections are actually regrowing cartilage in the knee. But there is a lot of research going on in this area. There's a recent product out of South Korea that's starting to enroll at various institutions in the US. Stanford just started enrolling patients that involves placental stem cells and injecting that into the knee. And so we're kind of on the cusp of hopefully coming up with something from a stem cell standpoint, but currently there's not really any legitimate stem cell therapy clinic in the US other than clinical trials. So when non-operative management fails in a young, active patient that's looking to get back to sports or high-impact activities, then we talk about knee preservation surgery. This is much less common than knee replacement surgery, so you may be a little less familiar with this, but kind of the two main ways we do this is by osteotomy, or realigning the bones, and then cartilage transplantation. So this is a depiction of what osteotomy is. So on the left x-ray, you see a patient with varus malalignment. I showed the alignment images earlier. You see that the mechanical axis goes through the medial part of their knee. And so what we do is we make an incision on the medial aspect of their tibia. We create a wedge, open up the bone, and shift them into a little bit of valgus, or back to their neutral alignment, and then we fix this with the plate and screws. So you see the right x-ray shows the post-operative films where the mechanical axis is now going essentially through the center of the knee, maybe even a little bit of valgus, in order to offload the medial diseased knee. So it's a pretty simple, elegant solution to counteracting this. And this is actually probably the single most powerful surgery that we can do in improving patient outcomes in a patient with early arthritis or early isolated focal disease in a patient with malalignment. We can do this correcting other deformities as well. So in a patient with valgus alignment, we could do the same surgery but take a closing wedge to close the side of the tibia. Or if the deformity is coming from the femur, we can do the same thing on the femur side as well. In addition to osteotomy, cartilage transplantation is another big treatment that we offer. So there's two main treatments for this. One is matrix-induced autologous chondrocyte implantation. And so this is where we go in with the first stage arthroscopy. We take a biopsy of cartilage from a non-weight-bearing portion of the knee. We then send it to a lab and they grow the cartilage on a medium and allow the chondrocytes to proliferate. And then this is then implanted onto the cartilage defect on a collagen scaffold. And it's shown to have pretty good outcomes clinically. We know biologically it's not actually regenerating the native hyaline cartilage, but they call it kind of hyaline-like cartilage. In contrast, OCA or osteochondral allograft is where we take a fresh cadaveric graft of bone and cartilage, and then we ream to size match the bone and cartilage plug to the defect in the patient, and then we implant or press fit that plug into the patient's knee. And this actually is probably the gold standard for cartilage transplantation. It's shown pretty good survivorship at 10 years, and it is the only cartilage treatment that actually has shown to reproduce hyaline cartilage or native cartilage in the knee. This is a picture that depicts each of these strategies. So on the left you see a patella that we did a Macy procedure. You see it's more of a flat sheet of cartilage that's going onto a smaller defect, less subchondral bone that's involved. And then on the right we see an osteochondral allograft where we're holding a plug of bone and cartilage from a cadaver that's been prepared, and we've already prepared the defect in the femoral condyle and are preparing to press fit that into the area of diseased cartilage. So when the cartilage disease progresses too much or to the point where we can't do any of these strategies, then we talk about joint replacement. There's two main types of joint replacement surgery, as you may have heard. One is partial knee replacement and one's total knee replacement. Partial knee replacement tends to be better for the younger, more active patient with single compartment disease. A lot of times we're debating doing a partial knee replacement versus a high tibial osteotomy or correcting their alignment because their indications tend to overlap. But a patient that is younger, that's not going to be running on it or participating in high impact sports, it tends to be a good candidate for a partial knee replacement. Versus an older patient with much less activity demand, with disease in all three compartments of the knee, we then talk about doing a total knee replacement. Both of these replacement options have pretty good long-term survivorship with the new technologies in metal and plastic that we're implanting. Even with the total knee replacement, we quote about a 20 to 30 year survivorship. And so even a patient in their 60s, if they're having a lot of knee pain and they have tricompartmental disease, the total knee replacement is a great option for them because in the majority of cases, it'll last them their lifetime. This is x-rays of each of these just to show kind of what this looks like. So you see the total knee replacement certainly takes much more of the bone and cartilage as opposed to a partial knee replacement. It's really sparing the majority of the anatomy of the knee. It's more kind of resurfacing the area of disease in the medial compartment of the knee. So lastly, in the last few minutes, I'll talk about some promising research that's on the horizon. You may have heard of this study out of Stanford. It was published late last year in Science. I was looking at this 15-PGDH inhibition in actually slowing or reversing cartilage degeneration in the knee. This was done in a mouse model, and they essentially found that blocking this specific enzyme in aged mice actually allowed the cartilage to regenerate, and it prevented post-traumatic arthritis after they did some insult to cause arthritis, such as sacrificing their ACL. So as opposed to working through stem cells, this actually reset the gene expression of a particular enzyme to a more youthful state in order to regenerate cartilage in the knee. So a lot of patients are asking about this because it's very promising, but I think we're still a ways away from this being clinically relevant. It's still certainly preclinical. There are potential risks that could occur in humans, and so I think in the next 5 to 10 years we'll have more information on this, and hopefully there's some useful, truly cartilage regenerative options in the next few years. So to summarize, we know that cartilage can't heal itself, and so early recognition, referral, even before a patient reaches the need for a knee replacement, can preserve our options that we have. Limiting impact activities and weight loss are powerful modifiable factors. Physical therapy and consideration of injections should precede surgery in most patients. In a young patient that desires to go back to high impact activities or sports or running, we can consider realigning their bones or cartilage transplantation. And then an older patient with goals of limiting other high-impact activities, we consider partial or total knee replacement. And finally, there aren't any current biologic options that truly regenerate cartilage, but there's certainly some promising research on the horizon. So thank you for your attention.
Thank you, Andrew. Anybody has any questions?
I have a suggestion. Thank you for a very good lecture on this one. I have a question regarding prosthesis with cementing and without cementing. How do you choose who's a candidate for a cementless prosthesis?
Yeah, so there's a lot of newer research that, so traditionally all of these total knees were cemented, so that's kind of the gold standard. In the last 5 to 10 years, they've popularized cementless total knee replacement. Right now, there's not a clear indication where you have to do cemented or cementless. It's more or less surgeon preference at this point. There are some studies that in obese or overweight patients, cementless knee replacement has better outcomes. That's been kind of the main actual risk factor that plays a role. Other than that, it tends to be more surgeon preference. And then the other thing is if the patient has poor bone quality, which oftentimes is only seen intraoperatively, then even if they were planning for cementless arthroplasty, they will switch to using cement because it's just a safer, more robust fixation.
Hi. Growing up, I was very athletic. I have climbed the Grand Canyon, all those things. Suddenly, 10 years back, while in India, I fell. My knee got twisted and I had a cartilage damage. It just disappointed me so much. So several orthopedic surgeons, everybody said arthroscopy, all these things you were talking. Finally, I went to Lubbock orthopedic chairman. It's a Vietnamese woman. She suggested, she said, you don't need any surgery. Good foot, shoes is very important, the preliminary. I suffered pain for 3-4 months. And Birkenstock is one shoes I have been using since then. Inside the house, everywhere. My pain completely went away. I took some physical therapy. I think starting with a good shoes will always help. I tell all my friends whenever they complain about knee pain.
Yeah, it's actually an interesting point. Some of that is comfort, but some of that is actually related to the mechanics of the alignment as well. A lot of these patients are flat-footed, and so when you restore their arch support, actually the alignment through the knee improves as well, and you can get improvement from that too.
Thank you. I have something to confess. He's my nephew, my cousin sister's son, and it's such an honor for me to give this award to him. And especially Tom Thomas, who was there, and my brother Alex. You all are his uncles and aunts, and it's such an honor for us. Thank you, Andrew. And he's third-generation physicians. His grandfather and grandmother were surgeons and OBGYN. His mom is internist. Uncles are family medicine. You just name it. Every specialty is covered in the family. Thank you. I'm so glad that I came for this lecture, number one. I am somebody who had stem cell replacement for the knee injury that did not do anything other than the pain. I had to give $5,000 upfront before they even take me. The thing that helped me the most is the PRP. After 2 weeks of the PRP, my knee was like new. So what is your opinion combining both?
Combining both PRP and stem cells? Mm-hmm. So I think right now, PRP, to your experience, is kind of, at least in the literature, is the most effective biologic treatment that we have. As you mentioned, the stem cell clinics, even though they promote regeneration, it's not really shown to do that. And so I think isolated PRP injection at this point is kind of the gold standard.
And the benefit of PRP goes away after 6 months, I hear.
It can, you know, we don't often have to re-inject PRP into knees. It's kind of a treatment that can have a longer term impact, but all of the injection therapies are very patient dependent on how long they last. Some patients it last 3 to 6 months, sometimes it lasts in their lifetime, so it's kind of hard to predict.
Thank you.
Thank you.
I invite our next presenter, Dr. Girish Alakat, to the podium. Dr. Alakat is an Orlando-based neurologist, epileptologist, physician scientist, and an associate professor at Loma Linda University School of Medicine. He currently serves as the medical director of the Advent Health Epilepsy Center, where he leads advanced clinical care and comprehensive epilepsy surgery programs. His professional work bridges clinical neurology with translational neuroscience, specifically integrating AI-driven brain signal analytics to enhance seizure production and surgical planning. Dr. Girish earned his PhD in electrical and computer engineering recently from the University of Central Florida, focusing on his doctoral research on the use of deep learning to identify epileptogenic regions in the intracranial EEG. Throughout his career, he has had prestigious fellowships and positions in institutions such as Johns Hopkins University, the National Institute of Health, and Riken in Japan. As a prolific researcher, he serves as a principal investigator on various epilepsy studies and contributes to the academic community through numerous peer-reviewed publications and leadership roles in medical societies. Welcome.
Thank you for that kind introduction, and thank you Akmg and team for giving me this opportunity. It's a real privilege. So I'll try to cover this topic which is of interest to everyone, but at the same time it's like pretty broad, right? It's so I'll try to go through as much as possible. So I have a couple of disclosures I mentioned. So I'm trying to cover why at all we need AI, right? So that's one question that I'm trying to ask. How do we make sense, or like how do we utilize it maximum, and what are the key risks and obstacles? So AI is not a new technology. Our brain has been using this technology for millions of years actually, right? So if I have the, do you see the pointer? You don't see my pointer, right? No. So basically the neurons use this Hebbian plasticity, and it is from that Hebbian plasticity the idea of neural network came from. Every time the neurons fire together, they wire together. That is one of the issues that we face in our epilepsy world. You know, like the more seizures somebody gets, the more likely they will have seizures in the future. So the same idea, you know, if there are some increased connectivity between neurons, which can be replicated in artificial neurons also, that's where they came up with this idea that, oh, you can use it as a tool. And the question is, how did we reach here? Like, why? The idea was there for years, but there was a confluence of multiple factors that came together in the last few years. Like on one side, the methods were developed, and secondly, the data storage were developed, and then the computational power. So they all came together around the last 10 or 15 years, and that's what led into this big level utilization of deep neural networks, and that's what we see nowadays. In terms of why do we need AI in medicine? So there is an explosion of information over time, and second issue is that it is the natural evolution of the technology over time. You know, like in the past, the amount of information was less. Over time, the amount of information that we acquire, store, process has increased, and that leads to the state where we we have a difficulty in processing the information by our brain. The first figure on the left side, you will see it is about the genetic mutations related to lung cancer, the knowledge in lung cancer that has developed over time. So initially we only had 3 classes. I mean, when I was studying in med school, we had like 3 classes of lung cancer. But nowadays, like depending on which particular gene is affected, there are multiple classes, and that leads into decision trees on like which kind of treatment options are going to be good, all those. And same thing, the number of medications in cancer has gone up exponentially. You can see that in the next slide. And one issue that we face in epilepsy world, for example, is the number of medicines have increased rapidly in the last 10 years. But when a patient comes to us and asks, oh, is this medicine going to work for you once I start that medicine? It's very hard to answer that question. You know, like you don't have a clear methodology to answer, oh, okay, you tried this medicine is the most optimal medicine, this will not cause any problem. That part is a difficult challenge for us, and the medical field alone is responsible for generating around 30% of the world's total data, and that graph shows the amount of data that we generate. 1 zettabyte is like 1 trillion gigabytes. That's enough for you know, if you run HD movie 36 million years, that is 1 zettabyte, and that is so over time, like we are approximately generating around 10 zettabytes of data every year. So how do we utilize that, right? So that's where the challenge comes. So this is a graph showing where our human cognitive capacity stands and how the data has gone up over time. Our like working memory can only handle around 5, 6, depending on like men handle a little less. So and depending on that, you know, like you cannot focus on too many things. And when you are trying to mistakes, you know, like just like we all were interns, we do make mistakes. So expect mistakes happening. So how can you improve it? So there are different strategies. Like one is about, I'll go a little bit more into what is prompting, prompt engineering, all those things. Then there are like safeguards we need to implement, like about making sure that we respect the absolute privacy and safety of the data, making sure that data is not shared in the wrong way, and you utilize it for pattern recognition. That's where the AI has maximum leverage. That's part of the reason AI has reached domains like pathology and, for example, radiology more prominently compared to, say, for example, family medicine or other fields. I will talk about a little bit other fields. I will talk about a little bit about the automation bias and all. So this is the landscape of the AI tools. Garden Variety, ChatGPT, Google Gemini, pretty much all of you are using, and a few more refined ones that are geared for example, open evidence. That's one of them that I use a lot, like, and a lot of physicians use it. The main advantage is that they really depend only on verified literature for learning. There is additional imaging related tools. I'm just mentioning, and this is not an exhaustive list. This is one area I want to point out, the pharmacology and drug discovery. That's going to see exponential increase in usage from the AI field actually, because I expect at some point, say for example, somebody is coming with epilepsy. That's my field, that's why I'm telling like that. So if they are having a certain type of epilepsy and I put genome data to the AI, they will be able to come up with, oh, this is the right medicine. Or at some point they might even send the data to a company telling that, oh, we need to make a molecule, new molecule to treat this patient. So that's going to happen. I'm pretty sure it's going to happen in another 10, 20 years. Then surgical procedure, I mean, that I was talking to one of our urologists yesterday, like they use this Da Vinci tool. I mean, there's several other tools that that has been used very, very commonly. Like one of them is Medtronic's tool. On the administrative side, like I know you pretty much a lot of you are using DAX pilot, basically ambient recording tools. Then on signal processing, that's one of my area of interest. For example, if you can, the main advantage of AI or main strength of AI is you have to have continuous data coming. So the field like EEG, where you can continuously detect signal changes. We have a new tool that has come for, it's an app that comes with Apple Watch. It detects seizures and reports to family members. So one of the issues that we face in the epilepsy field is like SUDEP. SUDEP means like sudden unexpected death of these patients. So like I actually have had patients unfortunately die. So nobody will be there to report that they have a seizure. So the app detects this seizure activity and it can real-time alert family members so that they can come and intervene. So that actually was very helpful for one of my patients. So, and then more patient engagement and triage that has been utilized by a lot of centers. Basically, the whole idea is to minimize capture as much data before the patient enters the room. So I will just briefly go on to, a lot of these are called LLMs, large language models. Most of you may be knowing what large language model. The whole idea is that you are inputting, why we have large language models, right? Why not other models? Because language is the biggest source of information that we have. There is other sources like signals, another source is obviously image. So the large language models depend on this idea of recording and learning from a lot of data, like they are learning from the web sources, books. And one important difference and sometimes there is a misconception that the idea is that it is learning and spitting out the data. That's not the case. It is learning and depending on what it has learned based on the existing language, it generates its own data. So that is one difference. That is the good side and that's the bad side of LLMs. So why it is like you already need to know what kind of model you are talking about. Like for example, Gemini is a different model. You cannot talk to Gemini the same way as OpenEvidence. OpenEvidence will be strictly thinking in terms of medical, medical related matters. But on the other hand, Gemini will be like, it will give you examples from art, it may give you examples from movies, all those things. So, you need to have that specific context incorporated in your prompt to give a better result. And the same idea that I was mentioning in the RAG, like augmented data retrieval. And another reason I'm bringing about the context engineering is like depending on like geographical settings, right? Like the way we treat some of the diseases in US is not the way you can treat in India or in UK. Every centers have different methods or approaches. So that is another thing that you may have to consider when you are incorporating your LLM. So other LLM potentials are, I'm not going into the individual details. A very interesting one for me is like making sure that the last one, accelerated protein engineering and targeted gene therapy design. That's what I was telling. Now, if at some point there will be a stage like you give the genetic data, say nowadays like there is specific epilepsy syndromes, for example Dravet syndrome, they have like only a one gene change. So people are coming with these ideas like, oh, there may be a different gene that may control how the second gene is being modified. So the LLMs are actually giving us better ideas into those kind of things. So why do we what are the options here in this case? Like there are different options that and just focus on the last line. Okay, there is a lot of data on that. So there are a few advantages for each of the LLM tools. The open evidence appears to be the most zero friction, more bedside friendly. Doximity has another tool. Doximity is it comes with a few other supporting systems, like you can use it for phone calls, all those things. But the question of whether it's more, they might have a little bit of bias. That's one concern I have. Google MedLM is only a platform that interfaces with EHR. So if you are already working on EHR to upgrade, that may be a method to go with. And same thing with John Snow Labs. And the DeepSeek, I haven't used it much. So these are the different LLM technologies are available. And then coming to non-LLM technologies, you know, like computer vision, pathology is a big area where people are using this non-LLM technology. Few other topics. I'm not going into the details there. So now the question is, can we trust the AI in medicine? You know, like the question is, we are already trusting and we are already moving and using it. So it's almost the stage where the horse is out of the barn. So we can't even ask that question, can we trust AI? So, but at the same time, there are strategies that we need to make sure that we don't make big mistakes. One of a few cases that I want to point out, one of them was about this NH predict case, which came where like they used an automated deep learning system to decide on whether the patient can go to the rehab or not rehab. They denied a lot of cases, but out of 90% of the cases, the doctors rescinded that decision, which means that the AI was making a big mistake there. And then about the ambient AI tool, the issue was that the data that was recorded as ambient tool got out into the general internet, and that was a big issue. It came up as a major medical issue. The more interesting one is actually the, or more relevant one is the University of Michigan experience, where they found that a tool that they developed to identify the early sepsis, it degraded over time, unfortunately. And it was not actually detecting 2/3 of the actual sepsis cases, even though it was showing a high accuracy rate and a very high reliability rate in the early stages, but it degrades over time. And it could be due to multiple factors, you know, like the lab methodologies might have changed, the nursing workflows might have changed, patient population might have changed. So that is one issue, and that's because of that it was FDA has come up with some of the rules actually. So I'm going into challenges of this AI in healthcare based on some of these experiences. One is like the lack of transparency, explainability. So I'll detail the explainability a little later. There is a question of data security, there is bias issue and misuse of AI tools. The FBA, has been catching up with this issue over time. It's the technology that is evolving, right? But ultimately, can we trust comes from whether it has benevolence, it has integrity, and it has ability. In 2021, FBA came up with a rule that the algorithms have to be open, but at the same time, they did not allow updating of the algorithms, the models, for example. But over time, it has changed. In 2024, the most recent update from the FDA allows for the companies to update. So that probably will address this Michigan issue that I pointed out about the sepsis. There is several other additional strategies that we need to improve. Like one is about the bias. Bias essentially means like a lot of these AI tools are trained on specific populations. For example, a lot of them are trained based on US. It may not be relevant, for example, in Japan or India. And the other issues like explainability, like the other questions about accountability. For example, when you are dealing with a Tesla car and it makes a mistake, who is responsible, right? Same thing you can ask about the Da Vinci tool that the surgeons are using, and it identified as the artery as a muscle and it got cut and it caused problems. Like who is more responsible for that? So there are different issues. One of them that I want to focus on is bias in healthcare. That it can be due to the data bias. That is what I was mentioning. Like a lot of models are based on USA. That means like, am I running okay in time? Like, not. 2 more minutes. Okay. I will be cute. So one is bias. Then another important point is about explainability. Let me skip through that. So this one. So like when models are looking at, say it's identifying a cat as a cat and a dog as a dog. Which particular details give it, or like which particular details are pointing to that decision? So that is called heat mapping, and heat mapping means like trying to answer what led the AI to that particular answer. That's often a question, and as the AI has been progressing, like in this case, linear regression is the easiest type of machine learning. The DNN is the most toughest. So it has been getting harder to explain things. But that is where we can really take advantage of the AI. Actually, like we can try to identify exactly what the AI is basing its decision on. If we don't use that methodology, we can get into trouble. So we definitely need to ask the AI companies, like whoever is coming to us, can you give us the details on like how that AI is going to make that particular decision? One example is this. Like this is a paper that came a couple of years ago. This hip X-ray has fractures at 2 locations. The third one. So if you are just looking at it, it is hard to make out. But once they heat map it, that particular location, and then you go back to the previous X-ray, you can identify where exactly the fracture was. So explainability is going to be one key issue that we should be focusing on. And same thing, I want to extend that explainability. This is one work that we had done. So it basically, the point is explainability also advances science. It enables us to push the edge of science further, partly because it tells that there is new clues. In this case, for epilepsy, we were able to identify that certain markers we never had recorded in the past. Anyway, so these are all great tools and great powers. So all great powers come with great responsibility. So we have to be aware of that there is this medical legal issues. So at least in the foreseeable future, we have to have the human in the loop, and we have to treat the AI as an intern, not as a complete autopilot. So that's going to be one of the standards that we have to be ensuring. Okay, I know that my time is going out. One important point I want to make sure is the explainability is relevant. But I hope I convinced that AI is important, that we may have to use it, and I'm going to tell you there's a lot more to come. Thank you.
Thank you, Dr. Alika, for this complex topic, very relevant topic. AI is here to stay, and I appreciate you.
Thank you.
I'd like to invite Dr. Bachu Abraham, the Akmg President of Michigan chapter, as well as a rehab physician. My father-in-law is a rehab physician, so I'm honored to have you here. Present this award to Dr. I cannot finish, okay. May I have Dr. Sarah Esau and Dr. Tom Thomas? Go ahead. Lisa here? Is Lisa? Ulrika here? I'm not sure if the coffee is being set up here or you have to go downstairs to Hudson. This is a problem we have with this hotel. I'm so sorry, so they're flipping it on us again. So you may have, and you only got 10 minutes. Okay? I'm so sorry to say that, but it is. Yeah, cut for now till we come back.
Stretch and run for the coffee and come back. Let's see how the cartilages are working.
Joji Burger. If Dr. Georgie Work is here, please come up to the stage area.
Multiple people have questions. Yes. A lot of information. Yeah. I mean, you can spend each one of them one day.
You get access to the slides.
I think so. For sure.
Just like I was trying to make
More than
pictures.
that, you can be, you know, that's it. You're writing report, all of that.
Well, I'm telling you because I tried to I always felt like a because I'm not a Kerala graduate. So I would never come because I always thought this is for Kerala school. It's such a fabulous thing, but then somebody said, no, we should come. You guys come.
Somebody stopped you. Somebody, where are all people on that? Adu nirthi. Varu. Adu actually I'm not. Thank you.
start soon, right now. Please be seated. The next presentation will be starting in 1 minute. Please be seated.
We should start. Let's all take our seats. Our next speaker is Dr. Deepa Menon. And we have Elsa introduce.
Dr. Deepa Menon earned her MBBS from the Madras Medical College in Chennai in 1991. She's
try to project. So I have no conflicts of interest. My interest has always been on neurodevelopmental disabilities and particularly in autism, and I hope at the end of this visit that, better not closer to me, right? So I hope at the end of this visit, I was told to talk about autism over the lifespan. It's a pretty broad topic, so I got a lot of slides and tried to go through as many as I could. But I hope by the end of it, we have an idea about how to make a diagnosis in your clinics. And also to sort of just touch upon some of the interventions to help our individuals with autism and children. So when we talk about autism, we're using behavioral criteria, which is based on the DSM, and according to the latest DSM-5, the two areas we look at are social communication. So we need to have all three of these characteristics in the social communication realm. So difficulty making the initial social interaction, if you're able to make the social connection, ability to maintain that social interaction at appropriate levels, and then also maintaining and difficulty like, with joint attention, sharing your play, which is like typical for children. So you have to have deficits in all these three regions to make the diagnosis in the social communication realm. And then any two out of these four, difficulties with change. If the kid's having a hard time with, they like the routines. They have a hard time with the change in the routine or there's a transition. They might have repetitive behaviors, which could be motor behaviors, vocalization, some mannerisms that they do over and over. Sometimes they might have some very intense focused interest. So I've learned about so many different topics over the years, about planets, about stop signs, about bridges, so different things that they can get attached to, and then either hypersensitivity or hyposensitivity. So any two out of these four. So to sort of put it together, the other thing which DSM-5 brought into kind was talking about, in the past you had autism was put into different sort of buckets, right? You had your Asperger's, your high functioning autism, PDD. Now we just put everything under the autism umbrella,
and then you sort of divide them into levels. Level 1, 2, and 3, 1 being the mildest and 3 being the most severe. And so I would say the kids who in the past were called Asperger's or PDD, they might come at a level 1, whereas the most severely affected, the children with autism, they would go on to level 3. And what we normally see in our clinics are the level 2 children. So another thing that we always get the question about is like, how do we diagnose autism? What are some things that we look at? So if you think about it, if you're in a pediatric practice, there are things which are typical, which come up with normal developmental milestones. So example would be like, how early can you look at some of these things that are presenting? So a typical kid is, looking and tracking and following the caregivers very early on. And then they're also looking for objects. They're trying to start interacting by 12 months. So you might have some inklings as early as 9 to 12 months. And there are certain things that we look for, in the past used to call pejorative like red flags, but now we say it's early signs, right? If you have a child who's not having the social smile, who's not connecting with their caregiver by 6 months, they're not doing the repetitive babbling, like trying to grab the attention of the caregiver by about 9 months. They're not using gestures. So one of the first things we look for is, are the children pointing? Are they following a point, what we call joint attention? That comes as early as 12 to 15 months. So if anytime there's any delay in those areas, you sort of suspect that something is going on. And at any age, if there is a child who has had a particular skill and then lost that skill, what we call regression, which occurs in a third of the children diagnosed with autism, that is a big red flag for us when you're doing developmental surveillance. So I just wanted, I know for interest of time, I'm not going to click on this video, but I would definitely say you should look at it. This was a video we created in our center, done by our director, Dr. Rebecca Land, who is a very prolific researcher in the field. And so this actually sort of compares children who are typically developing and a child with autism, so you can look at some of these characteristics. So in your spare time, please have a look at it. So again, just to reiterate, right, you're looking for the social communication deficit as early as 18 months. So even though as clinicians and experienced clinicians, we might be able to diagnose by 12 months, by 18 months for sure, you can make a diagnosis of autism. And the things we look for are like we talked about, pointing. If they're not pointing, they're not having the joint attention, they're not showing or sharing their interest. Anytime there's a language delay, the fact that they're not responding to the name, because that's one of the common things that parents come and say. They initially thought the child couldn't hear us, so we did a hearing test, because you could be standing behind the child and screaming, and they don't even turn around, but that you turn on Barney like 3 rows down the line, and then they sort of respond to it, right? The way they respond to sound, they respond to the name. The fact that they might be having some repetitive play, but they're not having a creative, imaginative play. They're not role playing, they're not doing action with their toys. And the fact that they might not be using gestures, and they have a hard time regulating their emotions. What about older kids, right? What are some of the things that might sort of make you suspect autism? If they're having difficulty maintaining eye contact. Again, this is not specific for autism, because you could see it in a child with anxiety. So just that the fact that somebody doesn't look at you doesn't mean it's autism, but it's something that might want you to start looking a little deeper. The fact that they might have a hard time understanding emotions. They might understand like broad emotions, but if it's very subtle, they might have a hard time understanding. The fact that a lot of children might have speech delay. The fact that they might be repeating things like repetitive behaviors or repetitive scripts that they might be repeating from Barney or Elmo or something, that they keep repeating a certain script or a word, or they might create their own words. They might have a hard time with change, with routines, with transitions. They might have restricted interests or any repetitive behaviors, like flapping, rocking, spinning. And they might have these sensory issues. Either they're very hypersensitive to things, like even a small sound can set them off, or they could just walk through and there's a big siren and nothing seems to bother them. The hypersensitivity to things. And restricted behaviors could be in different ways, right? They might have some odd attachments to toys. They might be wanting to line things up. They might be having a hard time with playing. There's repetitive mannerisms we talked about, unusual fixations. The fact that some of them actually create rituals because they seem to be more comfortable when there's a ritual. And we talked about these changes. One oft-repeated statement that you hear from both parents and providers is, you see one child with autism, you've seen one child with autism. Because even though you have these 2 core features which are very prominent, the way they're present can be very different. And why is that, right? Because language levels, I sort of divided into thirds. Like a third of the kids have normal conversational language, basic language, and they struggle with the higher language functioning, like difficulty with pragmatics. They don't understand humor, they don't understand jokes, they don't get sarcasm.
A third of them have no language at all, or they had language and they lost it, and now they have to use a device or some other way of communicating. And a third of them might have some language, just a limited functional communication, and that's again aided by augmentative communication devices. Cognitive delay, I would say at least 60% of them have some borderline to mild cognitive delay. If there is syndromic autism, like Fragile X or tuberous sclerosis associated with autism, and just because of the genetic defect, they might have more severe cognitive delay. The type of onset. If you have a really severe form of autism, I have parents who tell me right from day one, I knew there was something wrong with my child. I'm nursing this child, I'm hardly able to get him to see me, right? And these are experienced moms. And then there are some that I only see when they're 14 and 15 because they've been able to math so well, and now they're presenting as teenagers. So the way they present it, and then like we said, a third of the children have what we call active regression. They had some language, but between the 18 months to 3-year period, they actually lose language, or they get like stereotypic behavior and become more florid as autism. Medical conditions are some conditions more associated with autism. Example would be like seizure disorders are more prevalent. They have sleep disorders, GI issues are much more prominent in individuals with autism. And then what I spend a lot of time with, because I can't cure autism, I can actually treat some of these other comorbid things which we see with autism. About 60% of the kids with autism have ADHD, another 20% have ADHD and anxiety, and then you have like mood disorders, significant behavior issues. So those are the things that we see in our clinics. And then there's always this thing, because I remember when I was in med school, autism was a line in pediatric textbooks, right? It's a very rare disorder, 1 in 2,000. And then now we come to the latest added, epidemiological data is on the incidence or prevalence is 1 in 32. So what has been going on? What makes this change? So I would say that I would attribute to the fact that one is the DSM classification has changed, right? When you talk about how Kana described it, he was talking about the most severely affected individuals with significant intellectual issues, very clear kind of autism. Then we went through this phase where we had this burgeoning and different classifications. And now, so that's a big contributor, the way those characteristics of autism are changed in DSM. The fact that, AAP, the American Academy of Pediatrics, has done a great job, and parent groups like Autism Speaks have done a great job in talking about autism. So more people are actually screening and suffering at an earlier phase. Pediatricians have been really good at doing these autism screens, which have been, devised by the AAP. And the fact that before 1990 and 2000, autism was not a way you could get an IEP in school or special education in school. But then you see after late 1990s, once the educational diagnosis of autism came in, then you see again a steep rise. So I think these things are all contributing. And there's always this question about epigenetics. What has changed worldwide? Because the incidence of autism is the same across the world. So that brings into play the fact that maybe there's a genetic component, something has changed in the environment, and there's an epigenetic component to all these things. So again, we're talking about, like we talked about, such an interaction about the fact that autism is not occurring because of vaccine use. Right? We know that this is something which is acting really early on, right from conception onwards. And depending upon where the insult occurs, the presentation of autism could be really severe. And there are a lot of different theories, right? We know that older parents, both dads and moms, but there's a little bit more bias with older dads. The incidence of having, and you're talking about older, you're talking about dads who are in the 60s plus, right? And the chance of having a child with autism is much higher. The fact that it's been associated with obesity, with mitochondrial disorders, with thyroid issues. So and also the fact that we know that a large part of it is because it's driven by genetics. So you might have a genetic predisposition. You might have maybe the mom had an infection. There's like twin gestation, multiple pregnancies, something which is perturbing during your antenatal period, or any of these other comorbid things. So it's multifactorial as to what could cause autism. There's never a single reason why you have autism. So I put in some slides about the different theories about autism, the fact that maybe there's an inflammatory component to it. Like we know that slides have shown that there's microglial activation, especially in kids who are having some regression. So that's one theory. But the strongest fact that is driving, and the more that we're understanding about autism, is the fact that genetics is a big driver of what could be underlying autism. So when they come to us in like an autism center, most of the time in your pediatric practice you're doing an MCHAT, and maybe some parent screeners, but then when they come to an autism center, the gold standard is to do an ADI and an ADOS. An ADI is a parent report. The way it should be done, it takes a good like 40 minutes, sometimes it can be 2 to 3 hours, so it's not feasible in a busy clinic. But in research, this is the gold standard, right? So we take components from the ADI and put it into our history taking. But what we do in our clinic is it's like a joint, a speech therapist will do an ADOS, which is a play-based evaluation. And there are different modules of the ADOS, depending upon your language levels, which goes from non-verbal, toddler, all the way up to conversational speech. And they're looking at these two component areas, your social communication, your repetitive behaviors, the social reciprocity. And with that, you get like a quantitative score that can tell you, yes, this child is most probably has autism, maybe on the borderline, and no autism. So that helps us when you're making. But again, like I tell my residents, it's a tool. Ultimately, you as a clinician use this as a tool to help you make the diagnosis. And a clinician's judgment trumps even, because I've had a lot of patients who have positive ADOS, but I see them and I'm like, this child really clearly doesn't have autism. It's a speech and language issue with anxiety, and it's not autism, right? So your clinical judgment trumps even a test. But this is a tool that you need to use. And like I said, there are like different parent tools. The MChat is what is done very much in all the pediatric practices. There are some parent questionnaires like the SCQs or the SRS. I like using the CARS, which again is also recognized by different insurances. Like if you're a pediatrician in a small town, you could use a CARS in your clinical judgment to make the diagnosis of autism. And this gives you it's a very objective view of looking at these characters and coming up with a score. And it's got a T-score, it's weighted, and insurances will look at that as making a diagnosis of autism. I would say if you take anything away from this lecture, I would say, if you think about autism, there are different things which could look like autism. So if you have a child with significant intellectual issues, language issues, and anxiety, they can look like they have autism, right? Same thing if you have very bad ADHD and language issues, you could look like you have autism. So the role that we play is to sort of rule out all these things before saying somebody has autism. So like you said, you want to rule out, language issues, ADHD, anxiety, and also clearly understanding that sometimes autism presents with these things too, right? So you have, like we talked about, 60 to 70% of them have ADHD, another additional 20 to 30% have anxiety and phobias. You could have mood disorders, cognitive delay is a big one. You could have a learning issue, right? Or sometimes you could have this little, what they call like quirky kids, very gifted. They have a hard time with the social interaction because they're cognitively much above their peers and they're not able to make the friends because their interests are very different from their peers. There's nothing wrong with them, they just think differently, right? So instead of saying everybody's autistic, making sure that you're making the right diagnosis for the right patient. And then this whole other thing we think about is, the girls, like in most things, similar behavioral diagnosis, girls sometimes are underdiagnosed. And what could be some of the reasons? One is we feel like some of the tools that we use, like the ADOS, might not be actually picking up, maybe like too crude and not picking up autism in girls. Because again, girls are socialized differently. So their social interest or their repetitive interest might be something that is socially accepted. I had a girl who's very interested in horses, so everything you talk about is horses, but horses is much more socially accepted than talking about a bridge or a stop sign, right? So some people say, oh yeah, that's just what she is, or she likes to talk about Dora, but Dora is accepted, but if you talk about, the switchboard, that is completely different. So maybe we're not really picking it up. The girls are presented very subtly. And there's always this diagnostic overshadowing that girls and females are given a mental health diagnosis of anxiety or mood disorders rather than autism. And why is that important? Because this is from a large study from the Simons Foundation. And where they actually looked at it and they found that the girls are diagnosed with mood issues, boys might be presenting more as an ADHD diagnosis, but in general, their girls are being detected at least 2 years after boys tend to be diagnosed. And the other thing that we see and we learn from self-advocates is that some of the girls with autism, they're very good at what's called camouflaging or masking, right? They're able to hold it together in public spaces like school, but it takes a lot out of them. By the time they come home, they're exhausted, they're tired because they've used their whole cognitive strength to remain in compliance with what is expected of them. So this leads to what, and for example, I would say an example of a girl who came in and said, oh, you look so pretty, look at your earring, look at this. And I was like, oh, this child doesn't have autism. But the mom looked at me and said, do you realize that everything she said was from this particular show? I'm like, I don't know the show. It was some cartoon thing, but she was exactly repeating the same thing. And I only realized this because in 30 minutes, by the time my visit was done, she came up with the same script. But it was very appropriate. She was talking the right thing. Oh, you look pretty, look at your earring, I like your dress. And this is exactly from a show which she had seen. So the girls are very good at mimicking. And I also had parents who say, yeah, my daughter, every year she'll pick one girl in the class and she will do everything the girl does. Right? So they're learning from their peers, but they're learning to mask. So they're able to do it, but they really don't understand the content of why they do certain things, why somebody laughs. They don't get the meaning. They don't have the theory of mind, but they're able to mask because they're very bright. Right? So they have these sort of superficial skills. They're very interested in social interactions. And they might have some, like we said, gender normed interests, which might not be sticking out, so they're not picked up that easily. So the other thing to think about is the fact that, there are a lot of things like we talked about in general. Like this was from a Kaiser study from a few years ago where they looked at individuals with disabilities compared to individuals with autism. And across the board, some of these conditions were much higher. Like the GI issues, sleep issues, obesity, seizures are much higher in individuals with autism when compared to other developmental issues. And so Autism Speaks has been great in coming up with algorithms for practicing pediatricians on how to work with families with constipation, on feeding issues, on sleep issues, because individuals with autism also have difficulty either falling asleep or staying asleep. A lot of the time we try behavior therapy or like group-based therapy for this, but in some cases you do have to put them on sleep medication. And then epilepsy, like we're talking about. Just the fact that you have autism increases your risk of having seizures. And if you have autism with intellectual issue, that actually almost doubles or triples your risk for seizures, and sometimes intractable epilepsy. And if you have certain syndromes like Angelman's or Fragile X or tuberous sclerosis, Smith-Magenis, the risk of having intractable seizures is much higher. And then the biggest change, I would say, in the last 5 to 10 years has been this understanding about knowing that there are certain genes or multiple genes associated with autism. Right? You might be with certain chromosomes, but also certain hotspots in certain chromosomes, but also certain genes like your SHANK and your neuroligands, which are all important for synaptic work and neurotransmitter region that might be causing autism. And the hope is, if we find at the end of the day, we want to have some sort of a cure. So maybe studying these single gene disorders might give us a clue as to what causes autism, and that might then lead to some therapeutic options. And like we said, anxiety and depression is very high. Studies have shown that, especially with self-advocates, high-functioning individuals with autism, the risk for catatonia and suicidal ideation and completed suicide is much higher. So that is something that we actually had to adapt current screeners like the ASQ and the DSSA, so that we're able to actually screen for this. And this is one area I would say everybody should be doing is, in your practice, screen for depression, for suicidal ideation, because these children are at very high risk for getting bullied, they're having a lot of microaggressions, they're being socially isolated, and that can lead to severe mood issues and depressions. If I can make a plea, I would say please do a suicide screen, or at least in your practices, because I think that changes the trajectories for these young individuals. As medication is being used, but again, it's the very last thing that we use. Usually we're starting with behavior therapy and supportive therapy, but then there are medications that we use. None of them are perfect, but my rule is, start low and go slow. If they say you're starting anxiety treatment with 5 milligrams in your typical pediatric patient, I start with even half of that, which might seem like this minuscule amount, but that's all they need sometimes. So don't rush to, push up onto high doses. Start very low, go very slow, because these kids are nonverbal. Sometimes you really don't know what they're reacting to, and don't attribute everything to autism. These are children, so they respond to medication, so please rule out other things before saying everything is because of autism. So there are different therapeutic interventions, but the mainstay of everything is behavior therapy, right? So you have a strong behavior therapy, but then you also have supportive therapy, which could be speech and OT, family support, and these are all things which go to it. So most of our children actually come with like their team, right? They have a medical person, they have a psychiatrist, they have a therapist, a speech therapist, OT, so it's always not a single person doing the therapy. And there are different kinds of behavior interventions. Some of them are very adult or teacher directed, which would be like based on ABA or applied behavior analysis. And then you have the child directed ones, which are like floor time and DIR. Just put in some information about ABA. ABA has had a bad rap recently, and it's not something that every person with autism needs, but in individuals who have significant behaviors, ABA does make a difference. I think of it as a teaching methodology because it's like you're breaking down the tasks into smaller components, you're doing positive reinforcement, and you're trying to build positive behaviors, right? It has to be individualized, and then you have to involve the families in it. And sometimes a good autism program has both the child-directed and it's eclectic. It has to be a mix of different therapies, it's not one or the other, right? And you also do social skills training for our higher, to teach them how to do conflict resolutions, how to play with your peer, how do you go for a job interview. So these are things which can be taught through social skills training. And then a major component of a lot of what we do is communication. So teaching them either using visual supports, you can create like schedules for them, or even using a device which can now talk to them. This is another question that comes up is, having a device, does it prevent kids from speaking? But what we find in research is that early introduction of AEC, kids actually getting a model of how to talk a particular sentence, they learn to repeat it, and that actually fosters communication. We also use social stories. It could be non-verbal language, where you're coming up with the whole social story so they have predictability. And sometimes you might also have like a whole written script that might be helpful. OT is used both to teach adaptive skills, but also for sensory integration, and also to teach some introspective thinking. And then in the work world, we use something called teach, where you're learning how to get ready for the work world. You're learning to work through a particular system, you're starting a job, finishing a job, and teaching independent skills, right? And then we also use family therapy, because having an individual child with autism can be pretty draining. I've had families either get together very quickly, or there's also high risk of divorce. So working with families is very essential. We have a big cadre of care coordinators and social workers as part of our teams, and that is what has really been helpful, giving them resources in the community, but also giving family therapy. So, and then, like anything, complementary and alternative medicine is a big part of what I discuss with my families. Again, there is very limited evidence base. So sometimes you have to be the voice of reason for the parents, giving them permission to stop some of these things, or even giving them the information that we had. Like all of you were saying, stem cell therapy was big a few years ago. Before that, and now it's all about leucovorin. So it keeps changing every year. I've heard everything from stem cells to dolphin therapy to immunoglobulin. Very limited evidence base. Hopefully we'll get to learn more as more and more people start doing research on this. So what I want to say is, it is a lifelong disorder. It's not that you're going to lose the diagnosis of autism. The characteristics might change. There's limited information about alternative therapy. What we know is things like speech therapy, OT, ABA really does seem to change the trajectory for our children. Families should be part and parcel of what you're doing. But any therapy that you do, you should look at the functionality. What is the function of your therapy? What is it that you want to get out of it? So like I tell my families, everything, it's like painting a house. You don't keep painting the house over and over again. What's your start date? What's your end date? What do you want to get? Get some measurable data so you can see the change. And if it's not working, go back to the drawing board, talk to the therapist and say, this is not my goal. This is the goal I want to work on. You have to take charge of it and be a strong advocate for your child.
Anyone has questions?
I have a question. We see a lot of children being diagnosed with autism in Kerala now, and there is a lot of cell phone addiction going on in especially young children. Even when they're like 1 or 2 years old, they are cell phones are used to distract their children to engage children. So the increasing cell phone use, does that contribute to autism? I know it's genetic, but how much role does it have?
I would say not directly to autism, but any electronic for sure increases behavioral issues, even with typical kids, right? I see that all the time. That, parents are coming in, you try to take the phone away from them. They're going to have a behavior issue. So I wouldn't say it's a direct. It's like saying, eating nuggets causes autism. No, it's an association. But you do see an increase in behavior issues, and also the fact that being on electronics and any games and social media does decrease your attention span. Whereas in the past, kids could sit and do a task for like 15-20 minutes. Now, getting them to do it for 5 minutes is hard. So AP has been very strong at saying, don't have them on electronics for more than, an hour a day or even less than that. And that's what I tell my parents. We were very good at it, then we had COVID and everybody was on the computer 24/7. So it's a relearning, but I always tell families, if possible, like especially toddlers when they come in with what I suspect is autism, I'm not really sure. I tell families completely do like a cold turkey. Don't let them do any electronics for at least 6 months and then come back and see you. Because again, all these things are very passive. What we want is even if they're using phones, if they're on their phone, make it an active thing. If you're watching Barney, pause and make it an interactive thing, so just like passive watching. So that might change the trajectory again. And again, it improves your interaction. What we want is to foster social interaction between a parent and a caregiver, parent and a child.
Excellent talk, Deepa. Thank you for that overview. We all need to be aware of this. Appreciate it. My question is, you touched upon antenatal events that's contributing, but is there any study on intrapartum events? We see prolonged deceleration, flat tracings. Should we do something differently? Has there been any association with what part of the brain is particularly affected? Any placental studies associated with outcome?
So I wouldn't say direct link. Again, we do look at some of these higher things. If you have prematurity, if you have multiple pregnancy, anything which is perturbing your normal pregnancy, that increases it. Chorioamnionitis is big for both CP and autism or any neurological disorder. But intrapartum wise, I would say anything which is, of course, low of gas, but having a rupture, of course, that increases the risk. But I wouldn't say that is causing autism. I think it increases your risk. It is like what is causing those issues. What maternal factor, was she exposed to? We do know that there's also like a slight increased risk of now with illicits and cannabinoids and alcohol. Those are things that I do screen for because that just increases your risk of neurodevelopmental disorders across the board, especially cigarettes. We don't even think about it, but that's a big one. Cocaine, cigarettes, alcohol, all those things for sure. And then infection is a big one. There have been studies looking at neuroinflammatory markers in moms. And there was a one through the NIH where they said, yes, there were some like interferons and some of the pro-inflammatory markers were elevated in individuals, the parents, the moms, that led to increased risk for autism. But again, very preliminary studies, nothing like ATP connection for sure. So, but it's intriguing. I think there is a big maternal component to it, which we don't look at. I know at Hopkins, at the School of Bloomberg, they've been looking at all these environmental and maternal factors. There are some indicators, but no direct links.
Thank you. Like listeners, I'm also interested. It was a very informative topic because quite a few children, almost all the children with autism are sent to our clinic for hearing assessment because of the inconsistent response. You answered, Sarah, partly about the social interaction and the electronic devices. But over the last 10-15 years, there is, anecdotally, there is a significant increase in referrals. Do you think it's only because of the classification difference or any actual increase in the numbers?
I think it's a combination, like I said. I think there is the change in the classification, the fact that they're recognizing it and they're screening for it. Because I know when I was in med school, we never screened for autism. They were all like classified. I think I saw my one patient with autism when I was in the mental hospital, right? Because they were classified as intellectual issues. So maybe they were being misdiagnosed as something else. And then this whole environmental factor, that interaction, I think that is what might be causing an increase. I don't know if that
One more quick one.
I'm a pediatrician. I used to work in an Air Force base in Lubbock. A lot of children, family in stress, they bring children, or do they have autism? They're trying to parenting skills.
Yep.
I found majority was parenting skill, advising and all. What is the percentage of that you see in your practice?
So we have like a PDD clinic where our behavior psychologists do that with a lot of our families, where they're working with the parents to teach them, because sometimes, like again, any child is going to try and get the attention. If there's any attention is better than no attention, so across the board children will do, they know what to do to get their parents' attention. But sometimes when it's maladaptive, it's like the interaction. So we do have parent therapy, which our social workers and behavior therapists work on that. And then again, it's like teaching expectations, right? Sometimes in a high functioning kids, you're thinking that the children with higher functioning, they might have ADHD and executive functioning disorder, and your parents will expect you, now you're 16, you're supposed to be doing everything on your own, and these individuals are not able to do it on their own. So it's like matching the parents' expectations to the child's ability, and if that doesn't match, then trying to figure out what's the parent training component, what's the child component that we can do.
If no questions, I have an observation or an aha moment when I was sitting here. One of your slides, the ASD diagnostic criteria DSM-5, criteria B, repetitive speech, movements, or use of objects, adherence to routines and rituals, restricted or intense interest, unusual sensory interest and reactions. That's all head and neck surgeons. Thank you.
I'd like to invite Dr. Sindhu Pillai, who is a pediatrician from California. She is our past president of Akmg. She will give the plaque to Dr. Menu.
So our next presenter, she lives 20 miles from me, according to my wife. 8,000 miles of traveling to see her, to actually meet her. That's when I met her, in Carroll. Dr. Sarah Yuso, MBBS, MD, FACP, is the medical director and consultant oncologist at Dr. Akmg Institute of Medical Sciences at Chenganur, Kerala. Dr. Yuso is a distinguished medical oncologist with extensive international training and leadership experience in cancer care. She completed her medical degree from Kottayam Medical College and pursued advanced training in the United States, including residency in internal medicine and fellowship in hematology and medical oncology at the New York Medical College. Dr. Yuso founded the Ocean Hematology and Oncology in New Jersey, USA, a specialized center for cancer and blood disorders, which later became affiliated with the Robert Wood Johnson Medical Center and Cancer Institute of New Jersey. Throughout her career in the U.S., she has held key leadership roles, including Division Chief of Hematology Oncology and Director of Cancer Committee at Monmouth Medical Center South. Her professional journey reflects a deep commitment to clinical excellence, research, and public education on cancer prevention and early detection. She is an advisory board member of ICCN, International Cancer Care Network. An avid writer, Dr. Yuso is the literary editor of Genity magazine and has published in many medical and non-medical articles. Dr. Yuso.
Thank you very much for that nice introduction. It's a real honor to be here, being part of the CME program, especially after listening to Dr. Pichmani and the other esteemed speakers. I feel very honored and privileged to have an opportunity to talk about breast cancer, latest advances in the management of breast cancer. If you need to talk about the advances in breast cancer, we will need like a 2 or 3 day conference. So I'm only going to touch base upon the most important and very superficial aspects of the advances that we have in the last few years in breast cancer. I have no disclosures. We'll have an overview of the breast cancer incidence, the diagnosis and staging, and the advances in systemic therapy. Systemic therapy is in the form of, it could be endocrine therapy, chemotherapy, targeted therapy, and most recent, immunotherapy. So the statistics of breast cancer, this is the most common cancer among women worldwide. In the United States, about 297,000 new cases are diagnosed with breast cancer every year, and we have about 43,000 deaths from breast cancer in 2023. And the median age of diagnosis in the US is reportedly 63 years. And the one good thing is that the mortality from breast cancer has significantly declined in the last few years. This is mainly due to the advances in systemic therapy and implementation of screening, and also detection at early stages due to the wide implementation of breast cancer screening. In India also the breast cancer is the leading cause of cancer among women now. In the past it used to be cervical cancer, and due to the advances in screening and widespread implementation of pap smear, we have seen a decline in cervical cancer. So breast cancer is the most common cancer among women in India as well. So how do we diagnose breast cancer early? So we have heard about mammograms. Mammograms can detect cancer in the preclinical phase before symptoms appear. So any screening for a cancer is when you have no symptoms and you can detect the cancer. So breast cancer is one of the few cancers where it is possible to detect the cancer, and now thanks to AI we can even implement this screening to a next level where even when the radiologist can, wherever the radiologist cannot even appreciate a mass, with AI techniques we can detect the masses early on. And why do we need to diagnose early? Because if you diagnose early, there is a chance of cure, a better chance of cure. Why don't people screen? Because this anxiety, there are some false positive cases which may lead to unnecessary biopsies, but the main important barrier in getting screening is because of the anxiety of women from going through a test like that. So it was shown by studies that mortality in breast cancer can be reduced by 22% by routine use of screening mammograms. Mammogram is an X-ray examination of the breast, as you all know. Initially, about a century ago, the X-rays were used to examine breast tissue by German surgeon Albert Salomon, and the modern mammogram machines came into existence in the late 1960s. But since then, the technology have advanced significantly. The women who are here, who has gone regularly for mammograms for the last 20 years, will know the difference in technology and the ease with which mammograms are done now and interpreted nowadays. So modern machines are safe, and it uses the lowest possible radiation. One of the key things people always say that, is it safe to do mammograms? Am I not going to get a lot of radiation if I do it year after year after year? But the fact that the amount of radiation from the modern mammography machines is similar to what you will experience when you are just by walking around or just by living outside from the environment. The amount of radiation that you receive is similar to what you naturally get from the environment. So it's not considered an extra risk. So benefits outweigh any possible risk. And we have digital mammography, and now have 3D mammograms and tomosynthesis. I don't expect you to read that screen. It's the guidelines for doing a mammogram is based on your risk. If you are an average risk woman, the recommendation is to do an annual mammogram starting at age 40. Annual clinical examination and annual screening mammograms. And you will do the mammograms up until your life expectancy is at least 10 years. So people ask me, I'm 70 now, should I still continue the mammograms? Or I'm 75 now. But if you are otherwise healthy and you are expected to live for another 10 years, yes, definitely you should continue the mammograms until you reach a stage that you're debilitated, your other comorbidities, and your life expectancy is not that long. So there are some women who are at increased risk with their family history of breast cancer, some carriers of genetic mutations such as BRCA1, BRCA1 and BRCA2. So when you have a high risk of developing breast cancer, you have to start screening at an earlier stage. So especially if you have a prior history of breast cancer, you should be starting, the family members also should be starting screening earlier. So sometimes we tell patients, if you are the youngest member in your family had breast cancer at 45, then you should be starting 10 years early. You should be starting screening when you're 35. So the screening for high-risk women is a little bit more earlier than average-risk women. So high-risk women have to do a clinical encounter every 6 to 12 months, and you don't do mammograms before 21, but you have to screen when 10 years prior to the youngest family member who was diagnosed with breast cancer. You can also consider doing an annual breast MRI. Most of the time the MRIs can detect lesions that are smaller, that cannot be usually detected by a mammogram, because especially in young women who have dense breasts, Mammograms sometimes can mask masses, but MRI will be more helpful to do that. So in high-risk women, we also advise them to go for MRIs in addition to mammograms. So why do we need to screen? So the white spots in the circles are small lesions that are detected by a mammogram. These are not clinically palpable. Even if you go for a clinical examination or even if you do self-breast examination, you are not able to find these masses. So if you detect this at this stage, we have a phrase in Malayalam, if you can just nip it in the bud. If you can nip, if you see this, when you go for an annual mammogram, you can get treatment. If it is malignant, then you go for surgery. Then your chance of curing this is 100%. But if you don't go for screening, sometimes you may end up with this. It's just in this day and age, it's very unfortunate that we'll still see a lot of women, educated women, coming to the clinic with this kind of a lesion, even though all the screening opportunities were available. I'm talking about in the United States. So we'll switch gears to go into the staging of breast cancer. Like most solid tumors, breast cancer is staged from stage 1 to 4 based on the TNM classification, tumor size, nodal status, and whether or not there is any metastasis to distant organs. So tumor size, if it is smaller than 2 centimeters, and if there are no nodal metastasis, it will be stage 1. If there is any metastasis to the lymph nodes in the axilla, or if there is a tumor that is larger than 2 centimeters, it will be stage 2. Tumor that is bigger than 5 centimeters or fixed, or if there are more axillary nodes, it will be stage 3. And when it goes to other organs, such as liver, bones, or lungs, you call it stage 4. And why does stage matter? Because stage and diagnosis determines your prognosis. If you diagnose breast cancer at stage 0 or stage 1, your chance of living 5 years is 100%. We use the 5-year mark as a 5-year survival rate as a benchmark for cancer. If somebody was diagnosed with cancer and if you are living without cancer for 5 years, that means you have achieved a cure. That's most often the case. So we use that 5-year survival in oncology as a benchmark. So stage 0 to 1, 5-year survival is about 100%. Stage 2 becomes 93%, and stage 3 becomes 72%. And if you are diagnosed with stage 4, you have a chance of living up to 5 years, up to 22%. It's 5-year survival, not disease-free survival. So I want to just to show the advances that has happened in the last several decades. I want to discuss a case, a hypothetical case. A patient in 1996, that's when I started my oncology career. A 45-year-old woman, Mrs. M. She was premenopausal. She came with a palpable breast mass. Biopsy showed infiltrating ductal carcinoma, grade 2. Did not have any nodes in the axilla, no distant metastasis. We analyzed the tumor for estrogen and progesterone receptors. They were positive. So she was offered either modified radical mastectomy or lumpectomy with axillary dissection. After the pathology, her tumor was at 2.5 centimeter. 1 out of 20 nodes had metastatic cancer. She was treated with her clinical staging was T2, N1, M0. She was offered 6 cycles of chemotherapy followed by tamoxifen for 5 years. So once you are diagnosed with cancer, what should you know? There are certain things you need to know about your cancer. You need to know what stage it is. The stage also is involved. Stage also is dependent on the size and the lymph nodes. You also need to know hormone receptors. These are receptors on the surface of the cancer cells, estrogen and progesterone. And what's not available in 1996 was a test called HER2 testing, which is a protein on the surface of the breast cancer cells. And whether you're HER2 positive or not determines a lot about your prognosis, which we will come to in a few minutes. And then you also should know what is your risk of relapse. And early stage breast cancer, you need to know, do we need to do any further therapy after surgery or radiation? Most often the patients come and say, the surgeon said he took everything out, and why should I get more treatments? And that's a very common question medical oncologists encounter, because they're saying, surgeon said he took everything out, it's clean, why should I get more treatment? The fact is that the surgeon takes out the visible tumor with a clear margin, but there are cancer cells that could be inside your system which can deposit in other parts of the body, metastasis. They can metastasize anywhere from 6 months to like 22 years later. So this metastasis can happen in the liver, bones, lungs, brain. So the risk of relapse is always there, and we have to assess the risk of relapse based on several factors, the ones that we have mentioned here. And depending on that risk, we decide what kind of treatment you would need after your surgery. So what kind of surgery? I mean, I'm not a surgeon, but there is a question, lumpectomy or mastectomy. Then there is radiation therapy and there is systemic therapy. So these are the treatment for early breast cancer. We remember from the medical school era learning about the Halsted procedure. This is several centuries ago. Halsted had this surgical procedure which involved a detailed surgery, removing the entire breast and the chest wall muscles, very disfiguring surgery. Entire axilla was removed. It always involved a lot of morbidity. Of course, that is the best thing that was available at that time. So surgical techniques have improved over the last several decades and last several years, and then now nobody does Halsted procedure anymore unless it's a very deeply attached tumor. The surgeons do a modified radical mastectomy where the breast is removed but the chest wall muscles are intact, and then axillary dissection is part of that. And after that, a few years later, we found that, or the surgeons found that, doing a lumpectomy and doing radiation to that breast is equivalent to doing a mastectomy. So if you have a 2 centimeter tumor, if you can get a good margin around it, you don't need to remove the whole breast, as long as you're capable of doing breast radiation. Axillary node involvement is very common in breast cancer, so we have to always examine if there is invasive breast cancer. We have to always find out if there is any involvement of cancer in the axillary nodes. So again in the old days, all the lymph nodes were removed. So what happens after that? You get lymphedema. Your whole arm gets swollen. So there was significant morbidity associated with axillary dissection. But now we have sentinel lymph node biopsy, where you inject a dye into the area of the tumor and then track down the blue dye or the nuclear medicine material into the nodes, and you remove 1 or 2 nodes that drain from this tumor. If that tumor, that nodes have cancer, then you can decide whether to go for a full axillary dissection or not. But if there is clinically positive axilla, then you have to do an axillary dissection. But most women can be spared of a full axillary dissection and thus reduce the incidence of lymphedema by the sentinel lymph node biopsy. In some cases, you cannot do a breast conservation surgery if you have multicentric disease or you have diffuse suspicious calcifications, or if there is positive margin after the re-excision. And then if you are pregnant and develop diagnosed breast cancer, you are not able to get radiation therapy, so you will have to have a mastectomy if the treatment is done. In some autoimmune connective tissue diseases involving the skin, you cannot do radiation, then you will have to do a mastectomy. And this particular type of breast cancer, called inflammatory breast cancer, and there is a lot of skin involvement, so you have to go for a mastectomy. Now we talk about systemic therapy. So there are 4 different aspects of systemic therapy. Adjuvant, which is something that is given for a early breast cancer after the breast is the tumor is removed to prevent the risk of cancer coming back. That's called adjuvant therapy. There's neoadjuvant. In some cases, we need to give treatment before surgery to shrink the tumor, and that's called neoadjuvant therapy or preoperative therapy. Then there is when patients come with metastatic breast cancer, then there is systemic therapy involved there. And sometimes treatment is used for chemo prevention, mainly with tamoxifen or anastrozole to reduce the incidence of breast cancer in people who are high risk but does not have cancer. So there are subtypes histology-wise is ductal and lobular cancer. Then hormone receptor positive, the estrogen receptor positive and HER2 negative. The other subtype is hormone receptor negative but HER2 positive, and then all 3 being positive, HR positive and HER2 positive. Then there is a subcategory called triple negative, which is a very aggressive form of breast cancer where you don't have hormone receptors or HER2 receptors, and typically triple negative breast cancer is very aggressive and the risk of going to other organs or metastasis is very high. So now there is newer classification based on HER2 and hormone receptors, luminal A, luminal B, HER2 enriched and basal subtypes. So we talked about doing the risk assessment. There is a newer assay. In addition to the grade and the hormone receptors, there is a test called genomic assays. One such test is called OncoTET-DX. So you assess 21 genes in the breast cancer specimen, and based on the presence or absence of this gene, you can calculate a score. It's a predictive as well as prognostic test. It gives you an idea whether how the prognosis is, whether the cancer is going to come back or not, what is the risk of relapse, and it also gives you an idea whether chemotherapy can be beneficial or not. So by implementing this genomic assay, we have cut down the number of chemotherapy that we give to patients. Even in patients who had, like we described earlier, with one lymph node stage 2, if she had a recurrence score of on this genomic assay, a lower recurrence score, she could have omitted chemotherapy. And a stage 1 breast cancer where we may not give chemotherapy, if they have a high score, then we have to give her chemotherapy. So we have using precision models to assess the risk of breast cancer coming back and then giving them systemic therapy based on that. Like I said, chemotherapy and endocrine therapy, targeted agents and immunotherapy. So we want to talk a little bit about targeted therapy. So this is the most advanced treatment for many cancers. Dr. Girish mentioned about molecular markers that guide treatment in lung cancer. So there are some proteins on the surface of cancer cells which we can target. Instead of giving chemotherapy that can kill or that can attack normal cells, the targeted agents only attack those specific proteins that are on the surface of the cancer cells. So if you have an analogy, I can say, let's say you're playing caroms and you are hitting all the coins with one striker, then that is like chemotherapy. So you're striking all the, and without targeting anything, you're just striking. But you're only going for that red one in the middle, that's target therapy, because you're only going for that particular cell with that target on the surface. So target therapy has really made a difference in the management of cancer in many cancers, and breast cancer is one of them. You can see that endocrine therapy is a target therapy because it targets the hormone receptor positive patients only. If your hormone receptors are negative on the cancer, you're not going to benefit from endocrine therapy. Another very important target therapy advance is HER2-directed therapy. Then there are newer medications which are inhibitors of other mutations on the surface of the cancer. So I'm not going to do details, I'm going to be into the details of this slide, but this shows you the advances of target therapy in breast cancer. Starting from 1978, when tamoxifen was introduced, we are adding more and more medicines every year. Medicines that can target the endocrine system, which is hormone receptor positive cells. Medicines that targets HER2 positivity, and there are some targeted agents for triple negative breast cancer, which are usually seen in BRCA1 mutated patients. We are using this group of medicines called PARP inhibitors. So target therapy is now plays a major role in the treatment of breast cancer. So most of the breast cancer, 75% of them show an ER/PR positivity, and it's generally lower grade cancers, most frequently seen in post-menopausal women, and overall prognosis is better compared to hormone receptor negative cancers. But in hormone receptor positive cancers, you can even see the cancer even after like 20 years. So it can come back in 20 or 25 years because it's relatively low grade, grows slowly. So tamoxifen was the way to go in the 70s and 80s, but newer medicines which inhibit the aromatase inhibitors and reduce the production of estrogen in our body, they also come into play. So in patients who are postmenopausal, instead of tamoxifen, we are using more of the aromatase inhibitor. So the tamoxifen is an estrogen receptor modulator. So the cancer cells have estrogen receptors, so they modulate this receptor, so they fight for this receptor. So in that way, the tumor growth is downregulated. So if you compare to tamoxifen to AI or aromatase inhibitor, which is an enzyme regulator, and helps reduce the production of the estrogens in the body, and the benefit is seen there, especially it's mainly in postmenopausal women. Another target is the CDK4/6. These are CDK4/6 is an enzyme that is activated by cyclin D1, and down regulating this will give reduce the cell production. This medicine have been used in the treatment of early breast cancer as well as metastatic breast cancer. Initially, they were introduced in metastatic breast cancer, where the cancer has gone to other organs. This CDK4/6 inhibitor tablets were given along with hormone treatment, and they showed that there was a significant improvement in the outcome. So now they have brought that into adjuvant trials as well. So early breast cancer. So if somebody has a high risk early breast cancer, tumor is big or the lymph nodes are high in numbers, in addition to the endocrine therapy, this is only for hormone receptor positive patients. In addition to the endocrine therapy, if you add either abemaciclib, which is one of the CDK4/6 inhibitors for 2 years, or ribociclib, if you add that for 3 years, there's a significant improvement in disease-free survival. So now CDK4/6 inhibitors have come to the treatment paradigm, treatment armamentarium of early breast cancer as well. So when somebody comes with the metastatic breast cancer, the treatment is purely based on whether you have hormone receptor positivity or not. Hormone receptor positive, we'll add endocrine therapy along with the CDK4/6 inhibitor, and if it is HER2 positive, then you have to add HER2 directed therapy. If you are triple positive, then you do both. But if you are triple negative, chemotherapy is the only option, and the latest is immunotherapy that has found to be beneficial in triple negative breast cancer. So there are 3 main CDK4/6 inhibitors. I'm not going into the details of that. Let's talk about HER2, HER2. This is the HER2 is overexpressed in about 15 to 30% of invasive breast cancer, and it's associated with the high-grade disease with most people present with larger tumors, nodal metastasis, and sometimes with metastatic disease to the other organs. So there are other cancers also where the HER2 can be seen, such as stomach cancers, in ovary, esophageal cancer. So nowadays it's a practice to test all metastatic tumors for the presence of HER2 receptor on their cell surface. So this is a slide that shows how HER2 is important in predicting the prognosis. This is before the era of the targeted agents for HER2. The purple line at the bottom is where the probability of overall survival was shown. Compared to a luminal A hormone receptor positive breast cancer, the prognosis of HER2 positive patients were very, very bad. It was almost similar to triple negative breast cancer. So we knew that HER2 was bad, but we didn't know what to do about it. Until they came up with this targeted agent called trastuzumab. Trastuzumab was studied in patients who have metastatic cancer with the HER2 positivity, and compared with control, there is a significant benefit in the outcome of patients who received the HER2 target agent. This study, when it was published in the ASCO annual meeting, they got a standing ovation. This was one of the landmark studies because this has made a difference in many hundreds and hundreds of women. This medicine has helped them live longer from what was once considered to be a dismal prognosis. There are women who are getting the trastuzumab-based regimens for like 5 to 10 years. So this has really been a very important mark in the history of breast cancer treatment. So based on trastuzumab, there are newer agents. I'm not going into the details of that. But this drug, trastuzumab deruxtecan, is the latest one in the HER2-directed therapy. And again, this is the studies when they compared trastuzumab deruxtecan to the basic trastuzumab, the effect was very prominent, and now this is used widely in the treatment of early as well as later breast cancer. So another mutation which is associated with a bad prognosis is PIK3CA, and again it has shown that if you have a PIK3CA mutation, your prognosis is bad. So there are agents who target that mutation, and that has improved the prognosis of this. PARP inhibitors are used in triple negative breast cancer, especially if you have a BRCA mutation. And last but not least, immunotherapy. We must have heard a lot about immunotherapy in cancer. Immunotherapy treatment is basically stimulating your own immune cells so that the immune cells can fight cancer. So immunotherapy medicines have made a tremendous impact in cancer treatment, especially in lung cancer, head and neck cancer, and a few other cancers. But breast cancer, there was not such an impact until recently when the studies showed that if you have a triple negative breast cancer and if you have this marker called PD-L1, if you're PD-L1 positive and metastatic breast cancer, triple negative, you add immunotherapy to the standard chemotherapy, people have a better survival. Now, most recently, it is also brought into the neoadjuvant treatment of triple negative breast cancer. To shrink the tumors, if you give immunotherapy along with chemotherapy, your options of going into a remission or going into a pathological remission is high. So, these are the two areas where immunotherapy is used in the treatment of breast cancer. So, we will go back to the case. In 1996, the patient had ER/PR positive stage 2 cancer, chemotherapy for 6 cycles and tamoxifen, had a mastectomy. Now, in 2026, if that patient comes to us, treatment will be very different if we have to check the HER2 status. Instead of doing an isolated dissection, we can do a sentinel node biopsy, so we can avoid the risk of getting lymphedema. Now, the risk of relapse can be assessed by doing a genomic assay on that cancer specimen. Then we can base the chemotherapy decisions based on that risk. And then, if depending on the risk, we can also offer CDK4/6 inhibitor, and we will do a genetic testing on anybody who comes with the breast cancer these days. Number one, to help with the family. If they have a mutation, we have to screen the family. Also to guide the treatment, because there are BRCA gene positive patients who can benefit from this medications called PARP inhibitors. So nowadays, in the old days we used to test only if you have a family history or only if you have a very young age breast cancer, but now almost everybody we offer a genetic testing. So the take home points are, not all breast cancers are alike. Stage by stage, prognosis can vary based on the hormone receptor status and HER2 positivity and mutational status, and also the genomic alterations inside the cells. So treatment is tailored towards each person. One size fits all does not apply anymore. Mainly in breast cancer, but in most cancers we have a personalized treatment plan. Thank you.
Hi, Dr. Issa. Thank you for an excellent presentation. My name is Sophie Yohanan. I'm Associate Medical Director at Boston Scientific, and I have a question regarding screening. So I know a physician who had negative mammogram and negative breast exam, and still a negative family history for breast cancer, still insisted on ultrasound, and there a malignant tumor was detected. And that saved her. She ended up having surgery, radiation, and chemo. So my question to you is, I'm curious, what is your opinion about ultrasound for screening versus mammogram or MRI?
Ultrasound by itself is not used as a routine screening tool because you may miss masses. If you have a palpable mass, you use that as a complementary method along with mammograms. But mammograms can miss breast cancer, especially if you have dense breast. So MRI will be the way to go. I'm not sure why the ultrasound showed the mass, which is turned out to be a good thing in that patient's case. But ultrasound is not a good screening tool for all women considered. There may be isolated incidents where mammogram is negative and you could find something on an ultrasound. But the key thing is when you have a dense breast, then MRI would be the thing to go.
Thank you, Sarah, for, as always, the wonderful presentation. My question is, if somebody is on tamoxifen or aromatase inhibitors for 5 years, and they are having a recurrence after 5 years, right? Then if you are adding Ibrance, you still continue that aromatase inhibitors or you change it?
So we'll go to, if they are getting metastasis while they are on the hormone therapy, then we'll go to the next step. So if they are on tamoxifen and they have a recurrence, then you go to an aromatase inhibitor. If you're on aromatase inhibitor like anastrozole or letrozole, then you go to the next step, you go to fulvestrant injections. So we always have to, because that is an endocrine failure, right? They got recurrence while they are on it. But if there was like a year or more between stopping the medicine and the relapse, then you can technically go back to the same. But by somebody on to marks in 5 years, they may be postmenopausal, then I would probably put them on an AI regardless.
I have a quick question. If you're stage 2A and you're on letrozole, is it 5 years of treatment or is it now extended to 10 years?
So the latest guidelines, depending on the risk, initial risk, recommends most women to go for 10 years. If you are at an early stage, like stage 1, I would say you can stop at 5, but that's kind of on the discretion of the oncologist. Some oncologists recommend stopping it at 5 years, even if you are early stage 2. So it depends on the grade you had initially, depending on how many lymph nodes you had, because there can be stage 2 if you have like the tumor was like 2.5 centimeter with no nodes, or you can have a 3 centimeter with 4 nodes. So that initial staging is very important to determine the risk also. So based on that, my personal preference, if you are tolerating the letrozole, I would recommend that I will give the option, you can continue it for 10 years. The downside to the aromatase inhibitors is osteoporosis, so you have to make sure that you do DEXA scans and protect your bones by bisphosphonates. Other than that, if you're tolerating it pretty well, I would like to, because the endocrine positive tumors can come back as late as 10, 15. I have seen a patient cancer coming back after 25 years. So it is very elongated. So if you are not able to, if you have no contraindications, you have no intolerance to it, I would say take it for 10 years. There is another testing which called breast cancer index, which can predict your risk of relapse up to 5. So not all oncologists use that routinely, but you have to go back to the original slide and do the breast cancer index, and that particularly just looks at the risk of relapse after 5. So that is a tool to you to determine if you will benefit from a 10-year course or not. But most of the time, it's okay to take for 10 years.
I have a quick question for you, Tara. For the neoadjuvant treatment, I'm not sure if you can answer it. So if they take the neoadjuvant treatment, you rescan before you proceed with surgery?
Depending on what kind of surgery you are doing. So let's say somebody has a 3 centimeter tumor, and based on their histology, triple negative or HER2 positive, nowadays the way to go is to do preoperative neoadjuvant treatment. So they can still get a lumpectomy. So if they were going to go for a lumpectomy, then we'll place a clip before surgery, before the chemotherapy, because sometimes you don't see the tumor after treatment. After 6 cycles, you may not even see the tumor. So we have to locate the tumor, we have to do the clip, and then surgeons would do a screening mammogram before the surgery and to assess the location and the size of the tumor. But if you're going for mastectomy, you don't need to, because,
Right, the question, the difficult part in that case, that the neoadjuvant never caught on, is that even if you shrink the tumor, you have to go back to the original size and margin. Right. So the surgery is not saving much in terms of the tissue and function.
Right, but in breast cancer, we do such a great job in some cases that you don't even see the tumor afterwards.
Thank you for excellent, exhaustive talk. One more question. In pregnancy, we have these women complaining of all kinds of pain and tenderness and mass, and we often don't want to subject them to much of screening. We do ultrasound, and then if there's anything significant, then ask for MRI, because you have to time the delivery depending upon the aggressiveness and the size of the tumor.
Right, yeah, pregnancy and breast cancer is a complex issue, so we need the obstetricians and the oncologists and the surgeons sit together, because they cannot have much radiation, they cannot have radiology examination, so that ultrasound is the way to go at that time. Thank you. Thank you very much.
Excellent talk, Dr. Sarah Isa, our CME chair. And it's my pleasure to invite Dr. Nisha Nijil, all the way from Canada. She's our CME chair, CME committee member, and is an endocrinologist from Toronto. And she'll present the plaque to her. I have a quick announcement to make before we go on with our last lecture. The lunch is going to be in the Hudson at 12:30. But before you go to lunch, if you're wanting CME credits for the abstract presentation, you have to stay, and Ruth is monitoring. So please stay just 15 minutes. The students will be done. They're
He'll be giving 5 minutes. We'll go right straight into the abstract presentation right after CME, and then you can go to lunch. Okay? Lunch is being served, okay?
Hudson is the 3rd floor. Our next presenter is Dr. Sonia Abraham.
Dr. Sonia Abraham is an orthodontist and owner of the Fox and Abraham Orthodontic Group. The locations are in Denville and Riverdale, New Jersey. She earned her BDS from the College of Dental Surgery in Moneyball. She then pursued her advanced dental training at Akmg University's College of Dental Medicine. She also completed her DDS and MDS in orthodontics. While at Columbia, Dr. Abraham was the recipient of the Dr. Hinman National Research Award. Her research on the paracrine activation extracellular signal-regulated kinase in vitro model of wounded osteoblasts was published in the Journal of Bone. She has served as faculty on the craniofacial team at St. Joseph's Hospital for several years, treating patients born with cleft lip and palate, hemifacial microsomia, Pierre-Robin sequence, Treacher-Collins syndrome. She has extensive experience treating complex orthodontic cases that involve surgical interventions. Her practice is also known for treating special needs patients from all over New Jersey. Thank you.
Thank you for that introduction. And thank you all for inviting me here today. It's an absolute honor. Since this is my first ever meeting to an Akmg meeting, thanks to Elizabeth's and KP's invitation, and I'm an unfamiliar face to a lot of you, I thought I would also introduce myself through my parents, who are both Trivandrum Medical College graduates. They both did their general surgery and anesthesia in Trivandrum, and if anybody here knows them, please let me know. I'd love to meet you as well. So, coming to my presentation, for most of the last century, my specialty of orthodontics and dentofacial orthopedics has been filed under elective aesthetics. And for most of that century, that filing was defensible. I, however, believe that it's no longer true. What I want to put to you today is a different proposition, that craniofacial architecture is a physiological variable and that it belongs in your differential diagnosis, the way body habitus, blood pressure, and glycemic control already do. Every one of you here manages chronic disease with a structural component you were never trained to look for. Obstructive sleep apnea, refractory inflammation, functional dyspepsia, treatment-resistant migraine. In each of those, the shape of the maxilla, the position of the mandible, and the way the teeth meet are upstream variables. Measurable, modifiable, and largely invisible unless someone chooses to look at it. Everything I present to you today here is peer-reviewed. The sources are on the slides and indexed at the end. My aim is narrow. I'm not asking you to practice dentistry or orthodontics. I'm just asking you to add 5 seconds of structured observation to an examination you already perform, and to know what to do with it. Before I get into the science of it, I want to establish why an orthodontist is standing here at all. Consider the surveillance opportunity. Between the ages of 7 and 17, a child in orthodontic care is seen more often than any other health professional. A well child physical is annual, so roughly 11 contacts across the decade that I mentioned. A general dentist sees you on 6 monthly recalls, which makes it about 20. Orthodontic observation and active treatment adds about 30 to 45 contact points. As recommended by the American Association of Orthodontists, growth surveillance happens first around the age of 7. Then appliance visits every 4 to 8 weeks for 2 years or more. That's approximately 3 times the contact frequency of primary care across the exact decade when the mid-palatine suture, the mandible, and the pharyngeal airway space assume their adult form, and the skeletal picture becomes legible. So the orthodontic chair is not primarily a treatment station. It's a longitudinal record of growth, airway, posture, hygiene, and habit captured at a high frequency on a well child during the only window in which the skeleton can be redirected without surgery. The question this talk answers is what we should be doing with that record. So I'm going to talk briefly about 4 independent pathways. This room is primarily all physicians, so I thought I will get you involved a bit as well. I'm going to talk about the respiratory, inflammatory, digestive, and neuromuscular pathways. The common denominator or structural driver in all these pathways is malocclusion, specifically skeletal malocclusion. And the matrix for these pathways I will be dividing in 3 categories. First, the structural substrate, which is what you typically tend to see. Next is the mechanism. And the third, or the endpoint, is where you see clinically. Let's start with the airway, because this is where the relationship between architecture and physiology is most direct. When we assess a patient for obstructive sleep apnea, we tend to look at the body mass index and soft tissue hypertrophy. Those most definitely matter. But the skeleton actually sets the boundary for these conditions, and the literature is now clear that it does so independently of the BMI. A short mandibular ramus, a steep mandibular plane angle, and a narrow maxilla are each statistically independent structural risk factors for pharyngeal collapse. Look at the profile on the left. Maxillary transverse deficiency produces a high, narrow palatal vault. Because the palate is the nasal floor, that geometry raises the nasal airway resistance. The patient converts to oral or mouth breathing. The mandible rotates inferiorly and posteriorly, and the tongue base is displaced posteriorly. Negative inspiratory pressure collapses the pharynx. On the right is the same patient after skeletally anchored maxillary expansion. Surgically separating the mid-palatine suture physically drops the nasal floor, widens the nasal cavity, and lifts the pharyngeal minimum. In this study that I'm showing the images of, the functional consequence was a mean 52% reduction in the AHI in adults, with improved overnight oxygen saturation levels. That is an orthopedic intervention producing a respiratory outcome. In children, though, this becomes a feedback loop rather than a static finding. And that's why timing matters so much. Let's follow the sequence. Nasal obstruction, whether allergic or adenotonsillar or skeletal, forces the child to open an oral airway. The tongue leaves a palate. The tongue is the internal scaffold that holds the arch width. So once it drops, the buccinator load is unopposed and the maxilla narrows. As the arch narrows, the vault rises into the nasal floor, the nasal resistance increases again, and the loop closes and reinforces itself as the child continues to grow. The phenotype is something that we are all familiar with: long face syndrome, elongated lower facial height, mid-face hyperplasia, habitual open mouth posture, and a retrognathic mandible. Now the point I most want the pediatricians to take away. These children don't typically present with, as adults do with sleep apnea. They're not sleepy. Nocturnal hypoxemia in a developing prefrontal cortex presents as inattention, behavioral dysregulation, nocturnal enuresis, and learning deficits. And it's these days all too quickly triaged as ADD and medicated as such. The window on the right is a reason for urgency. Between the age of 5 and 11, the mid-palatine suture is patent and orthopedic expansion works. Through the early teens, this tends to interdigitate progressively, and that window tends to close over time. I'll come to the next system that I'd like to talk about, the inflammatory pathway, which is one that's most relevant to cardiology and internal medicine. The premise is that mouth can function as a continuous endogenous reservoir of systemic inflammation, and that dental crowding is what makes it continuous. Stage 1, severe dental crowding and rotations create permanent stagnation zones, geometry that a toothbrush or floss cannot physically access easily. This is not a compliance problem, it's an access problem. Stage 2, shielded anaerobic biofilm matures, deepens the gingival pocket, and ulcerates the pocket epithelium, and at that point, the barrier between an established biofilm and the systemic circulation is a single compromised cell layer. Stage 3, bacteremia. This is not theoretical. Viable Porphyromonas gingivalis has been recovered from atheromatous plaque walls at distant sites. Stage 4, the liver response. C-reactive protein is upregulated, circulating interleukin 6 and tumor necrosis factor alpha rise. Stage 5, endothelial activation, destabilization of the bulbar plaque. The orthodontic lever is in stage 1. So orthodontic alignment removes the anatomic trap, and chronic periodontal inflammation that recurs after competent periodontal therapy is usually an architectural problem, not a hygiene one. The same circulating mediators reach two different receivers. On the cardiovascular side, we have endothelial activation, LDL oxidation, foam cell formation, and plaque instability. The corollary is, in literature, is true and encouraging. Periodontal mitigation measurably lowers vascular inflammation markers. Metabolically, that relationship is bidirectional. Malocclusion-driven periodontitis releases cytokines that reduce insulin sensitivity, while erratic glucose accelerates periodontal breakdown. Each arm feeds the other. So in a diabetic patient with recurrent periodontal disease, you can optimize with pharmacology alone, but we're leaving the structural inflammatory generator untouched. We all know that digestion begins in the mouth, but we, however, rarely check whether the patient possesses the mechanical apparatus to execute that step. Occlusal contact area is a rate-limiting variable. In patients with anterior open bites, severe overjet, and posterior crossbite, functional contact area is dramatically reduced. Measured particle reduction efficiency falls by 40 to 50% against a class 1 control. Larger particle size in the stomach increases gastric workload, limits nutrient extraction, and delays satiety. Restoring a balanced occlusion improves masticatory performance, normalizes nutrient uptake, and moves BMI trajectory in the right direction. This slide is for gastroenterology and immunology, and it's also a point for us as orthodontists these days. The mouth is the inoculating chamber of the digestive tract. A patient swallows their oral microbiome continuously all day. So oral dysbiosis is not a local condition. It's a daily bacterial dose delivered to the gut. Dental crowding and orthodontic appliance geometry harbor pathogenic overgrowth, and this has been found to be considerably more in fixed appliances, i.e. braces. These days, we have another option, removable appliance therapy with clear aligners. And they have been shown to materially lower the pathogenic spikes for a simple reason, because they can be taken out and hygiene can be maintained better. Therefore, orthodontic appliance choice has now a microbiological dimension as well as a biomechanical one, particularly in a patient with inflammatory bowel disease or established dysbiosis. Let's talk about chronic pain, and I see this in my practice as well. Patients who never seem to get better. Many here see treatment-resistant tension migraine, atypical facial pain, and chronic neck stiffness. We cycle these patients through NSAIDs, muscle relaxants, tricyclics, and botulinum toxin. If nobody examines the occlusion, that possible mechanical generator is never touched. An asymmetric bite, a unilateral cross bite, or a centric relation that the patient cannot repeat can overload the elevators, strain periodontal nociceptors, and release substance P and CGRP, the same neuropeptides involved in migraine. Repeated input to the trigeminal nucleus caudalis can sustain central sensitization and revert neck pain. When migraine, facial pain, or stiffness resist treatment, examine the occlusion. Bite normalization may reduce pain, clicking, and muscle tenderness. And the quality of life data matters. Bite normalization lowers oral facial pain and joint clicking, with measurable gains in emotional stability and social confidence. For the orthopedic surgeons, physiatrists, and physical therapists, the adult head weighs 10 to 12 pounds and balances on the C1 and C2 vertebrae through a web of cervical musculature and ligaments. Displace a mandible laterally, and you displace the skull's center of gravity. The body's non-negotiable priority is keeping the eye level. So what does it do? It compensates. The chain on the left is documented, not inferred. A unilateral crossbite causes mandibular lateral deviation, which in turn causes atlas axis rotation, loads the shoulders asymmetrically, tilts the pelvis, and alters the center of pressure. The pediatric evidence is substantial. A systematic review of over 6,000 children links craniofacial asymmetry like retrognathia and prognathic skeletal discrepancies to polar system instability and measurable gait disruption. So the reason to raise this with you is directional. We habitually tend to treat this chain from the ground up with orthotics, core strength, and spinal physiotherapy, not considering the maxillomandibular implications. For our aged population, geriatrics and neurology. Geriatric medicine has recognized a statistical association between tooth loss and cognitive decline for years and has largely attributed it to declining self-care. However, modern neuroimaging shows a direct physiological pathway instead. Mastication is a neurovascular pump. Chewing supports trigeminal input and perfusion of the hippocampus and prefrontal cortex. A collapsed bite, on the other hand, withdraws that input. The key word here is modifiable. Masticatory dysfunction is classified as a modifiable risk factor for cognitive decline, which places it inside a therapeutic reach that most dementia risk factors are not. In a patient over 60 with a collapsing posterior occlusion, preserving the chewing capacity is not just a neurological intervention, also a dental convenience. So, as I'm coming close to the end, I want to briefly touch on endocrinology and, did I miss a slide here? Yeah, sorry about that. Endocrinology and localized biomarkers. Alveolar bone that I'm moving teeth through does not remodel in isolation. Orthodontic tooth movement is a controlled bone remodeling event, and the systemic endocrine axis sets its rate. Thyroid and parathyroid imbalance can alter turnover. Bisphosphonates that Dr. Sarah mentioned earlier can slow or complicate tooth movement. So if you're managing a patient's endocrine status and they're about to undergo complex skeletal correction, that's a conversation worth having with the orthodontist or the oral surgeon before they start treatment. Second is the gingival crevicular fluid, analyzed by proton NMR, resolves a reproducible metabolite signature during tooth movement and gives us a local, real-time view. Serum levels report the systemic average versus gingival crevicular fluid reports cellular and osseous response at the site in real time, which lets us as orthodontists tune the force protocols to the individual patient rather than to a population mean. So this single slide holds a whole argument, organized by the variable you will actually use, the patient's age. Phase 1, ages between 5 to 11. The structural target is mouth breathing, narrow arches, and a patent mid-palatine suture. The intervention is maxillary expansion and restoration of nasal breathing. The systemic dividend is airway patency and protection of the prefrontal development. Phase 2, ages 12 to 50. The target shifts to severe crowding and asymmetric unstable bites. The intervention is comprehensive alignment and occlusal stabilization. The dividend is a lower C-reactive protein, the inflammatory load that I mentioned earlier, and relief from myofascial pain. Phase 3, 50 and beyond. The target is bite collapse and progressive masticatory loss. The intervention is occlusal reconstruction and preservation of chewing capacity. The dividend is preserved cerebral perfusion and neurologic rehabilitation. Based on the age, targets change, the intervention changes, but the logic does not. Correct the architecture, and the systemic risk profile follows. This is what I'd like to leave you all with. 4 observations, all available during the oropharyngeal examination you already perform. No additional equipment, no additional appointments. 1, respiratory. Look at the palate, the high narrow vault, or a patient sitting there with a habitual open mouth posture. That's airway restriction. Refer for maxillary expansion, administrative artifact. It exists in our training pathways, our billing systems, our insurance coverages, and our licensure. It does not exist in the patient. What I've shown you today is a single anatomical variable with documented consequences across the respiratory, inflammatory, digestive, and neuromuscular systems. That variable is measurable. It's visible in seconds, and uniquely among the risk factors you manage, it's correctable permanently, usually before adulthood. So I have 3 asks of you today. First, screen. Add the 5-second craniofacial look to a routine adult or pediatric physical. Second, refer on the 4 red flags. High arch palate, severe crowding, asymmetric occlusion, class 2 retrognathia. Third, and this is the one I most like you to remember, reconsider the resistant cases. Treatment-resistant sleep apnea, refractory inflammation, chronic functional reflux, atypical trigeminal migraine, and chronic pain. When pharmacology has been optimized and the patient's not getting better, consider that the problem may be architectural. So think of the orthodontist and how we may be able to help you help your patient. Thank you.
Thank you, Dr. Abraham. I will definitely think about you. You are close to me. You had a neck patient, so.
Yeah.
Quick question before
Sure.
we move on. Have you seen any difference in pediatric patients who get adenoidectomy and tonsillectomy by age 5 or in and around that age?
Usually, by the time I see them, it's around age 7 because that's when the orthodontists are recommended to be evaluated by evaluate the child. So I don't typically see a 5 or a 4-year-old. 6, 7, and beyond, up to early teens. My oldest patient right now is 76 years old. So I cannot answer your question in terms of if I've seen anything by 5, but I have seen effects of it beyond that. A lot of it is contributory, right? You could have soft tissue hypertrophy, but at the same time, it could be without skeletal issues. But if there is a skeletal issue, it just helps with the correction even more.
Thank you, Dr. Sonia Abraham, a good friend of the family. And oh, there was one question in the back. I'm so sorry.
As a practicing
That question? Okay, let me start.
practicing ENT and sleep medicine, I see that very valuable intervention by the orthodontist. But my question is that why delay this? Can you be done before 5 or 4 for IR?
Absolutely. See, a lot of factors come into play. That's a very valid question that you asked. A lot of factors come into play. A child who's 4 or 5, if it's a severe case, absolutely. But I would recommend waiting a little before they gain the emotional, what's the word I'm looking for? Thank you. Emotional maturity and be able to understand why a process is being done to them. A child of 4 or 5 is too young. It can be emotionally traumatic to them at that age. But if it's a severe case, particularly in cases with, with syndromes and other issues happening, then it's a valid point to consider starting early. But I personally like to follow them through and see when they're emotionally ready to handle appliance therapy. Does that answer your question?
Yeah, I think I'm transgressing to Dr. Tom Thomas territory because we get unilateral earache. You have to rule out a referred pain and cancer of your area. So that's one point. And from ENT point of view, many times tinnitus start after dental procedure. That's a last straw because of the relationship between trigeminal.
And my question is,
We get quite a lot of patients coming for balance or tinnitus, they say, early. So when we check, we always supposed to ask, you chew with one side or both sides. Chewing with one side will cause pain.
Feel the TM joint pain. Absolutely.
What advice we should give? Before I finish, when I started my ENT training in Trivandrum, we have a dedicated theatre, and so there was also a dedicated
anesthetist
And
thanks for bringing that.
Oh, yes, absolutely. She'll be thrilled. She'll be thrilled to know. So to answer your question, sorry, just give me a minute. Yes, believe it or not, when I have consults with patients who complain of jaw discomfort over time, I do ask them which side they chew on, we all tend to favor a side, right? And that asymmetric over time, think of it, we're chewing hundreds of thousands of times a day, and that progressively causes tension to an area. So the most conservative or least invasive first approach would be see if you can bite more evenly, and people have habits too. They tend to chew on things, pen caps. There are so many factors that come into play. I'm sorry that you see tinnitus after dental procedures. Orthodontically, on the other hand, we're trying to make it more even before, so the occlusion is more even, So hopefully that helps with the situation versus otherwise.
Yeah, we tell them it's not the dental.
Okay, thank you so much for all those wonderful questions. And we're going to call on Dr. Sarah Hammond, who's a dentist from St. Louis, and my sister-in-law.
On behalf of Akmg, and this is your first convention, and I'm sure there'll be many more you'll attend, God willing. And on behalf of Akmg, New Jersey chapter and convention, we honor you with this. Thank you. Thank you.
We are moving right along into the abstract presentation. We have 4 abstracts today. Please stay back because this is also part of the CME. And these 4 doctors, they are pursuing higher education in the United States. So please be supportive. There are 4 presenters, each of you have 5 minutes each for presenting your abstract. And then there are 2 minutes for questions if anybody has any. And we have 2 doctors who are reviewing, Dr. Thomas and Dr. Nishan Etchi will be our judges. At the end of the 4 abstract presentations, we will present an award for the first, second, third and fourth. And without any further delay, let's start with Dr. Navya Matthew. Dr. Navya Matthew completed her MBBS in 2025 from Amala Institute of Medical Sciences and is aiming to apply for residency for the upcoming March in 2027. A dedicated research enthusiast, she is presenting a study for which she served as a principal investigator under the guidance of Dr. Ashwin Umman Phillips, a medical oncologist. The topic will be real-world impact of mismatch repair, immunohistochemistry in solid tumors, a retrospective analysis from a tertiary center in India. Dr. Navya.
A very good afternoon to everyone present here. My name is Navya Matthew and I'm here to present my study titled Real World Impact of Mismatch Repair Immunohistochemistry Across Solid Tumors, a retrospective cohort from South India. So before I move on, I just want to recall your memory on what exactly is mismatch repair gene. So it's basically a spell checker. So it's normal for DNAs to have repair, to have mistakes when they replicate. So this mismatch repair gene comes into play and it helps us to repair any kind of defect in DNA replication. So this protein has 4 proteins in it. This includes MSH2, MSH6, PMS2 and MLH1. So if any one of these protein is defective, we call it as deficient MMR or dMMR. So why does this study matter? So dMMR has become one of the most clinically relevant biomarkers in modern oncology. This is because it helps us to identify Lynch syndrome, guide adjuvant chemotherapy and even determine eligibility for immunotherapy. Molecular testing such as RT-PCR and next generation sequencing are quite expensive and not widely available in India. Therefore, MMR-IHC is an affordable and practical alternative, but Indian real-world evidence remains limited. So the objective of our study was to assess the frequency and distribution of mismatch repair deficiency and to correlate dMMR or deficient MMR with clinicopathological features and demographic details. So study was done in a South Indian tertiary cancer center. We included 191 patients who had adult solid tumors and who underwent 4-protein MMR-IHC. Demographic, clinical and histopathological data was collected and analyzed using chi-square or Fisher-Exact test. So the cohort included 191 patients with an equal representation of male and female with a median age of 62 years. And it was found out that 14.1% patients had defective MMR or dMMR. And 20% of these patients had a significant family history. Now this slide shows us who was tested. So most of these patients who were tested belonged to the stage 2 or stage 4 cancer, and most of these patients had colorectal cancer. Now coming to the indications for MMR-IHC testing. Most of these patients were tested in order to plan adjuvant chemotherapy. The second most common indication was to plan immunotherapy, and the least common indication was to screen for Lynch syndrome. Now this is one of the most important findings of my paper. So although only 14% of these patients had defective MMR, it was found out that in these 70% of these dMMR patients, there was a change in the management, which includes adjuvant chemotherapy being omitted or offering immunotherapy to them, or modifying the adjuvant chemotherapy duration. Now coming to the another finding of my study which needs attention is that 70% of these dMMR patients had a non-classical protein loss pattern. So this has clinical implication. Limiting testing to only 2 proteins, that is PMS2 or MSH6, could miss clinically relevant patterns, making comprehensive 4-panel IHC a practice-changing recommendation. This slide shows us the number of protein loss patterns seen in these 14% patients. So overall, the dMMR prevalence in my study was comparable to the international studies. MMR testing had increased significantly in the recent years. Though 8 patients became eligible for immunotherapy because of their dMMR status, only 1 person actually got the immunotherapy. This highlights the affordability barrier in India. And only 1 patient actually underwent germline testing to diagnose Lynch syndrome. So in conclusion, dMMR was detected in 1 out of 7 patients, and it significantly altered managements in majority of the patients. So future multi-centric data are warranted to establish national benchmarks for MMR testing in Indian oncology practice. This study supports the integration of MMR-IHC as a routine, cost-effective tool for precision oncology in India.
Thank you so much. Thank you very much, Dr. Navya. It's time for 2 questions, 2 minutes.
Hi Navya, wonderful presentation.
Thank you so much.
And was this patient cohort selected before they underwent surgery? So it was a retrospective study. So I did my
In 2025, so all the patients from January 2021 to 2025 who underwent this 4-protein MMR-IHC was included in the study.
One more question regarding your second conclusion. How do you, it wasn't clear because slide was. Which conclusion? You had a conclusion about testing 2 more proteins, right? Based on this data, how did you arrive
At that conclusion. So because of the time constraints, I didn't go through the slides. So based on this data, the top one MSH2 plus MSH6, that is a classical loss pattern, and even the fourth one MLH1 plus PMS2 is a classical pattern. But all of the rest are considered non-classical patterns, and we found out that 70.4% of these patients showed non-classical patterns. So I just added this up and divided.
Very nice presentation, even as a cardiologist. So, a couple of things, we would like us Akmg faculty in US or people practicing in US, we would like to see these kind of studies happening in Kerala. So I would like to see how much available is even in rural areas, in rural Kerala. I would like to know about that. Second thing, one comment, I would like to, especially when you are presenting research in US, I would comment about the IRB approval process, because that's important. IRB approval, how did
Ethics board. Ethics board. Okay.
Yeah.
So my institute had an ethics committee where I got the approval from. And regarding a question regarding Indian and USA,
so this study is quite
inexpensive. So I feel like oncologists can generalize this study to all patients with colorectal cancer at least, because it changes not just, it helps us to diagnose Lynch syndrome, but also helps us to change the management based on their DMMR status.
I can put in a word there too, because so in stage 2 and 3 is routinely done IHC for MMR status, because it affects of the decision regarding giving chemotherapy. In stage 4 cancers, especially colon cancer and many other cancers, we want to check for MMR because immunotherapy is very effective in those who are deficient in MMR. So it's available. It's not very expensive, but those who are able to afford an IHC, we offer it to them. Thank you very much, Dr. Navya. We will go to the next presenter. Dr. Hala Majid. Dr. Hala Majid is an MBBS student graduate from Dr. Somerville Memorial CSI Medical College in Trivandrum, India. She is passionate about internal medicine and has gained valuable clinical experience working as a physician in India. She is currently pursuing opportunities to further her clinical training and career in the United States. Her topic is sarcoidosis, a non-caseating drama. Dr. Hala Majid.
Good afternoon, everyone. My name is Dr. Hala Majid, and I'll be presenting a rare case of hepatic sarcoidosis. So this case is called sarcoidosis, a non-caseating drama, mainly because of the diagnostic twists involved in the case. And let's start the drama. So hepatic sarcoidosis is very common histologically, and it's usually asymptomatic. But in some very rare cases, about 5 to 15% of patients, they have this symptomatic disease where they present with jaundice, abdominal pain, ascites, and portal hypertension. So the problem is in TB endemic regions like Kerala or even India, this is a big diagnostic challenge because it becomes a close mimic to TB. So we are presenting the case of a 60-year-old female who is a known case of type 2 diabetes mellitus. She came with complaints of chronic cough and abdominal discomfort since the past 5 months, and she had a history of being diagnosed with hepatic granulomas which were attributed to TB and was currently on ATT. And this was diagnosed in an outside hospital based on CT as well as a liver true-cut biopsy. So when she was admitted in our hospital, she came with complaints of icterus, hepatomegaly, hypercalcemia and deranged LFTs. A gastro consultation was placed and we were asked to send the biopsy for review to a higher center. And in the meantime, we managed her supportively and she was discharged stable on ATT. but just 2 days later, she became worse. She came with complaints of abdominal pain, vomiting, and worsening hepatitis, and this time with a clinically significant ascites as well. So we went back to the investigations done previously in an outside hospital, and the CT scan had hepatomegaly, hypodense liver lesions, as well as lymphadenopathy, and the biopsy at that point of time showed caseating plus non-caseating granulomas. And because Kerala is TB endemic, she was diagnosed with TB and ATT was started. In our hospital, we did the labs again, and we had increased bilirubin and A by G reversal and increased ALP showing a cholestatic pattern. We did an IGRE and Manto, and it came out negative. And even the imaging findings showed hepatomegaly lymphadenopathy with mild to moderate ascites. So at this stage, our main differentials were malignancy lymphoma versus granulomatous disease, TB versus sarcoidosis. So we did a workup to rule out the differentials. We did a bone marrow biopsy, which showed unremarkable findings, and lymphoma was ruled out. We did an ascitic tab, which showed a SAG of greater than 1.1, indicating portal hypertension. But the ascitic fluid did not show any malignant cells, and the AFBA was negative. During the course of her admission, she had a new onset AFib, and we did a 2D echo to rule out cardiac sarcoidosis. Again, it was unremarkable. MRI brain, because she had developed drowsiness and gait disturbance, to rule out neurosarcoidosis, and that again was unremarkable. And the diagnostic turning point came when the review biopsy that we had sent came out to have predominantly non-caseating granulomas. And this confirmed our diagnosis of hepatic sarcoidosis. And this is the slide review. And we can also see multinucleate giant cells in the liver biopsy specimen. So during our admission period, we continued to treat her with ATT before we got the review biopsy results, and the hypercalcemia was managed with IV fluids and calcitonin. The AFib was attributed to dyselectrolytemia, which we corrected, and she was also given rate control with metoprolol. Her glycemic control was done via insulin, and once the biopsy confirmed hepatic sarcoidosis, we stopped the ATT and we started her on prednisolone, 40 milligrams per day. And once that was started, the outcome was remarkable. She had increased toleration to oral fluids, her symptoms resolved, no more dyselectrolytemia, and she was discharged on steroids and UDC and has been stable on follow-up since, as shown in the table. Her last follow-up was last month on 24th, and even that showed sustained biochemical improvement. So this case highlights a diagnostic dilemma between sarcoidosis and TB in endemic settings, and mixed granulomatous features without any microbiological confirmation like in our case. It should definitely prompt a reconsideration. So the main conclusion is hepatic sarcoidosis should be considered in granulomatous liver disease presenting with hypercalcemia, ascites, and a poor response to ATT therapy, like in our case. And continuous diagnostic reassessment is very essential to avoid any sort of misdiagnosis and ensure timely management. That's the end of my drama.
Thank you. Thank you very much. Anybody has any questions for Dr. Hallam?
Yes, please. I'm curious, in view of the diagnosis of hypercalcemia,
yes,
was a vitamin D level done, and including both 25-hydroxy and 125-hydroxy vitamin D levels?
No, actually we had only done the calcium level, serum calcium levels, and that had shown to be hypercalcemic. But if you look at the studies, you can know, like we know that both TB as well as sarcoidosis can cause hypercalcemia. So there is no specificity on which it would that it would further help in diagnosis.
Thank you. Good presentation, but I just want
to make a point that in particular sarcoidosis does cause, that's one of the few conditions that elevates the 125-dihydroxy vitamin D.
Thank you so much for your knowledge.
Hey, hello. So this is Majid Padivana. Good presentation. Just I don't know, I missed it. Did you have a chest X-ray in this patient?
Yes, we did have. I actually could not talk about it, but
that's okay. Was it normal or did it show something?
It had a unilateral hilar lymphadenopathy, but no bilateral one that we usually talk about in sarcoidosis.
Okay.
Which again contributed to the dilemma.
Very good. Thank you.
Good presentation.
Thank you so much.
Just for a follow-up, atrial fibrillation in these people. atrial fibrillation in these patients could be because of the infiltrative cardiomyopathy due to cardiac sarcoidosis. So I don't know whether you got an echocardiogram. There are some features, in the echocardiogram even point towards infiltrative cardiomyopathy.
We did a 2D cardio and we did not have any evidence of cardiac sarcoidosis in those students.
Thank you very much, Dr. Hala. Ajit. So we'll move on to the third presentation. Third presenter is Dr. Anna Sunal. Dr. Anna Sunal is an international medical graduate from Kerala. She is currently settled in New York. She completed her MBBS from Amala Institute of Medical Sciences, Thrissur, and is CCFMG certified and is successfully completing USMLE steps 1 and 2. She is applying for internal medicine residency through the MATCH program for 2027, and she has a particular interest in gastroenterology. And her topic is hidden in plain sight, endometriosis presenting as bowel obstruction. Dr.
A very good afternoon to everyone present here. I am Dr. Anna Karen Sunal, and I'll be talking about a very rare case of acute bowel obstruction secondary to ileocecal endometriosis. This case highlights how endometriosis can closely mimic a malignant bowel lesion, and why clinicians should consider this in a patient of reproductive age group presenting with acute bowel obstruction. So, endometriosis is the presence of endometrial glands and stroma outside the uterine cavity. It is a common condition affecting around 1 in 10 women worldwide. It affects approximately, gastrointestinal involvement is seen in approximately 3 to 12% of women, and rectosigmoid junction is the most frequent location, according for approximately 50 to 90% of the bowel cases. And a right-sided endometriosis, presenting as an acute bowel obstruction without any overt pelvic disease is extremely rare. And that brings to our patient. My patient was a 37-year-old female presenting with a 4-month history of intermittent colicky abdominal pain, episodes of which have been treated in both the emergency and gastroenterology departments for multiple times. She was evaluated and managed conservatively. I'm really sorry. I'm sorry, can I begin again? I just blanked out. I'm really, really sorry.
Yeah, go ahead.
Just read the slide. It's okay.
I know.
Read the slide. Yeah, you can advance it, right? Yes. It's good. You're doing great.
Just a slide.
It's okay.
Yeah. Can I start again? I'm really sorry.
Go to the next slide. Yeah.
Alright, yeah.
What's going on with you?
She thinks she missed a slide. That's okay. It's okay. Go ahead.
Okay, so the patient was a 37-year-old female presented with intermittent colicky abdominal pain, episodes of which were evaluated and managed conservatively in both the emergency and gastroenterology department. And in view of her abnormal lab results, including a slightly lower hemoglobin and constant abdominal pain, a colonoscopy was done, which showed severe luminal narrowing in the ileocecal region, obstructing the advancement of the scope, and biopsies were also taken during the time. At this point, the important differential diagnosis considered included ileocecal malignancy, ileocecal tuberculosis, and inflammatory bowel disease like Crohn's disease. The patient later presented to the ER with severe vomiting and abdominal distension. On examination, her abdomen was distended with preserved bowel sounds and no signs of peritonitis. Apart from the inflammatory markers being slightly elevated, her vitals were stable, and a CE-CT was done, which revealed circumferential mural thickening and enhancement of the ileocecal junction with upstream dilatation. Even at this point, the major concern was ileocecal malignancy. Given the situation of the patient, a laparoscopic ileocecal resection was done, and it showed an inflammatory mass at the ileocecal junction with and a dilated distal ileum was observed. Histopathological examination finally revealed entrapped endometrial glands and stroma infiltrating the musculatus propria, confirming the diagnosis of ileocecal endometriosis. So the final diagnosis therefore came only after the surgical resection. So I have three major learning points from this case. First, bowel endometriosis is notoriously difficult to diagnose preoperatively. One of the reasons being colonoscopy samples the mucosa, while endometriosis can infiltrate deeper layers of musculatus propria. Second, although hormonal therapy is appropriate for a stable patient with symptomatic bowel endometriosis, surgical resection may become mandatory in a patient presenting with acute bowel obstruction. And finally, right-sided ileocecal endometriosis, even though if it is extremely rare and can easily be mistaken for an ileocecal malignancy. So a high level of a high index of suspicion will help avoid any delay in detection and management. In conclusion, although extremely rare, bowel endometriosis should remain as an important differential diagnosis in a patient of reproductive age group presenting with acute bowel obstruction. Thank you, and I'd be happy to take questions.
Due to lack of time, we have to move on because our lunch will be taken away. So thank you very much, Dr. Hannes. We go to the next presenter, Dr. Akhtar Sirajuddin. Dr. Akhtar Samil Sirajuddin is the son of Dr. Sirajuddin of the Akmg Emirates Dubai chapter. He did his MBBS in JSS Medical College, Mysore, India, and currently working as a research assistant at Government Medical College, Thrissur. He's a part of the Akmg mentorship group, and he's planning to apply for the 2027 mass cycle. His topic is mapping the broken clock, quantifying operational delays and their independent impact on patient satisfaction in a high volume tertiary emergency management. Dr. Akhtar.
Good morning, everyone. My name is Akhtar, and I work as a research assistant in Government Medical College, Thrissur, whose team gave me permission to present the topic quantifying operation delays and their impact on patient satisfaction in the high volume tertiary emergency department in the Government Medical College of Thrissur. Okay. Now, as many of the Akmg members come from government medical colleges in Kerala, I don't need to reiterate how backlogged a lot of the emergency departments are. So, in Thrissur Medical College, there is around 789 patients per day, or close to 300,000 patients per year. And in India overall, there are 150,000 patients who just come from road traffic accidents. Along with that, there's a lot of non-communicable diseases which account for the emergency presentations. Now, government TDs face overcrowding, fragmented care, resource shortages. This is one of the main complaints even now, and it has not changed even in the past 30 years. Now, because of these problems, it has also affected patient satisfaction surveys conducted overall in Kerala, and a lot of the patient satisfaction surveys show 30 to 65% of in government institutes compared to 65 to 80% in private institutes. So our objective was to find out operational intervals in each triage station in the emergency department, red, yellow and green zones, find the factors which are driving the delays across all the triage categories, and also using a self-attested questionnaire to find out how these delays directly translate to patient satisfaction. So it was, as we said, it was a cross-section study done over the course of 8 weeks, and time intervals at each interface, patient satisfaction score of 1 to 10, and it was done using SPSS 30 software for analysis and logistic regression and chi-square testing. Now, our results show that triage time was generally adequate. It was 4.8 minutes, meets the 5-minute national standard. However, the triage to door to physician time was a bit different. Red zone 7 minutes, yellow zone is 34 minutes, and green zone is 122 minutes. The national standard is generally adequate. The green zone, it is up to discussion even up to now. The national standard is still, some people say 240 minutes, some people say 120 minutes or even 60 minutes. The mean time gap, however, before any patient is seen is 33 minutes, which meets the standards. Now, the main cause of delay we found out was the diagnostic turnaround times, like CT scan, ECG, ultrasound. All of them in the emergency departments took way beyond 120 minutes, which is close to more than 2 hours, 3 hours. This is mainly due to the large patient overflow, which affects the diagnostic turnaround times. Specialist consultation time also is affected. As you see, medicine department or even OMFS surgery departments, they take 600 minutes, that's more than 10 hours, or even surgery departments, 400 minutes, which is almost more than 3 to 4 hours. These all departments take way too long for just seeing the patient which comes to the ED. Now, for disposition time is basically the time when the patient comes to the ED and then they are either discharged, admitted or transferred. It's around 252 minutes, more than 4 hours, which is much beyond the international standards as well as national standards. And the door to operation time for even emergency department operations were 483 minutes, which is way beyond, like emergency laparotomies also used to take at least 400, 500 minutes, which is more than 4 to 6 hours, which is completely unacceptable even today's standards. Now, at the end of the survey, we found out that dissatisfaction by provider group, thankfully, was not due to doctors mostly, but it was mainly driven by security and nurses. Now, the main reason when we asked patients about it was that a lot of it was due to staff communication and wait time. A lot of the security staff are not trained in patient satisfaction as well as communication. They have a lot of patient workload, so because of that, that could be the major risk factor. And also, the satisfaction survey was 6.58 out of 10. Not completely terrible, but still much better. It could be improved in the future. So our study limitations, however, is easy to identify. One is it's a single center study. It was only done in one hospital. It was an 8-week study, so we didn't do it for a prolonged period of time. It was a self-reported satisfaction survey because we used bystanders because they were the ones who were able to do it. And we didn't clinically link to any mortality or morbidity endpoints during the survey. Now, on basis of this research we've done, the triage we found that meets the standard. I'll explain in a later slide how it impacts compared to like international standards, but the triage meets the standards. The delays, however, we found were diagnostic and specialist access, and we want to find a QI model for high volume tertiary EDs. So this is how the percentage deviation from international benchmarks. Disposition time was 5 minutes, while ECG was 5% difference. However, ECG and consult deficiencies were 1,680%. And our recommendations are point of care testing to reduce the turnaround time, to have like a cashless emergency system for triage patients, set clear escalation pathways for any other neurosurgery or surgery calls, train security staff in communication and patient handling, and implement digital tracking and trauma registry so it can reduce workload of the staff over there. There's the references. Thank you.
Thank you very much. We'll give a few minutes for our judges to tabulate their.
Hello, excellent presentation. I have a couple of questions. Who was administering these questionnaires to the patients?
So these questionnaires are administered by nursing students as well as Bachelor of Physiotherapy students. Unfortunately, we don't have a lot of research assistant students in the Government Medical College Trishur, so we had to use students from paramedical fields to help assist with it. And this also could be another factor which could have changed the satisfaction surveys as well.
And you mentioned the time, how were these minutes calculated? Is it based on EMR or who was
So these patients, the recording assistants who were the bachelor students as well as nursing students, they had like a stopwatch, so it was manually calculated. We didn't have any.
My question was like, how do you know that someone was seen within 300 minutes or 600? Who was tracking care with retrospectively looking back?
Yeah. So it was we used charts, and based on that, like each stage, we used to have like a person like mark down each at what point this patient was transferred to which using this.
This is an idea for an AI startup. Develop an app, record it digitally, and make sure that it will be a good publication.
Yeah. Is there any other questions?
You also measure face-to-face time because you're waiting so long.
didn't account for that because we wanted to find out the major systemic delays rather than patient to physician delays. Patient to physician delays, like because it's a government institute, it would be much shorter than normal compared to like maybe in the US or UK like standards. However, it can also be a cause for the delay in the future. However, we didn't consider it a significant factor for this emergency department delays.
Thank you very much, Dr. Akhtar. This was very interesting. Thank you. So we have our judges are very fast to come to this conclusion, so that's really appreciate your time. We're going to announce the winners. We will have our winners. They'll get a cash award as well as CME certificates. So the winner of the abstract presentation, the first place goes to Dr. Navya Matthew.
Look over there. Look at it. Thank you.
Thank you. Second place goes to Dr. Akhtar Samil Sirajudin. Dr. Nina Thomas will be giving award to Dr. Akhtar. Thank you very much. Third prize goes to Dr. Hala Majid. Dr. Urmila Kolam will give out award to Dr. Hala Majid.
Look at it.
Thank you. And the fourth place goes to Dr. Anna Karin Sunil, and that award will be given by myself. Thank you very much to the judges, thank you very much to the audience, and congratulations and good luck to all four presenters. We wish you all the best for your upcoming match.
Excuse me, sir. Can you sit down, please? Thank you.
One more. Okay. Okay, sorry.
Keep smiling, keep smiling.
Thank you.
Pink.